interaction with you. My main focus would be to everyone, but I love junior resident. So may all the junior resident, can you please? Okay, okay, thank you. So I will be interacting with you more. So अभी मैं कौन हूँ एक मिनट के लिए भूल जाइए. Think that because these are the issues that we face every day and I hope you would also be facing every day. अभी ये सोच लीजिए कि मैं एक बहुत ही skeptical clinician हूँ और आप लोगों की जो माइक्रोबायोलॉजी डिपार्टमेंट रिपोर्ट जारी करते हैं आई एम नॉट हैप्पी विथ इट. सो जैसे कि यहाँ पे है कोई जूनियर रेसिडेंट नहीं है? अच्छा, राइट हैंड साइड पे है. आप लोग तो हो ना, आप लोग हाथ. सो कैन समवन हेल्प गिव देम ए माइक. ओके, माइक्रोबायोलॉजी में जो आप लोग रिपोर्ट देते हो ना, उसमें थिंक दैट आई एम ए क्लिनिशियन.
गुड आफ्टरनून.
गुड आफ्टरनून. तो थिंक दैट आई एम ए क्लिनिशियन एंड आई एम एंग्री विथ यू.
यस,
आई एम एंग्री विथ यू बिकॉज आप कौन सा एंटीबायोटिक ज़्यादा सेंसिटिव है, कौन सा एंटीबायोटिक कम सेंसिटिव है, मुझे नहीं बताते. तो क्यों नहीं बताते? आई एम ए एंग्री क्लिनिशियन स्टॉर्मिंग इनटू योर laboratory.
So actually thing is that कि हम लोग के रिपोर्टिंग तो करते हैं एंड वी मतलब कि जस्ट मेजर द जोन साइज एंड जोन साइज मेजर करके मतलब कि वी मतलब कि प्रोड्यूस द रिपोर्ट एप्रोप्रिएटली अकॉर्डिंग टू द जोन साइज.
ठीक है, तो वही मुझे प्रॉब्लम है ना. तो किसी का बड़ा जोन होगा, कोई किसी का छोटा जोन होगा. तो बड़ा जोन वाला ज़्यादा सेंसिटिव है, छोटा जोन वाला कम सेंसिटिव है. ये अगर इंफॉर्मेशन आप हमें देते तो हम बड़ा जोन वाला एंटीबायोटिक पेशेंट को देते, है कि नहीं?
राइट सर.
तो ये माइक्रोबायोलॉजी से मुझे बहुत प्रॉब्लम है. थिंक दैट आई एम ए क्लिनिशियन. एक्चुअली आई एम ए हार्डकोर क्लिनिशियन with skepticism against microbiology department.
So I will just accept the critic and जो उनको चाहिए I will just deliver.
अच्छा, तो आप मतलब अगर क्लिनिशियन ऐसे एंग्री होके आएंगे तो आप बोलेंगे कि you will start reporting that antibiotic A is more sensitive and B is less sensitive.
I will do.
Okay, would someone like to counter or accept his verdict? इस बेंच पे. अच्छा, यहाँ से मुझे सुनना था कि आप लोग ज़्यादातर एंटीबायोटिक मार्केट में 20, 25, 30 40 है, कोई भी है, लेकिन आप लोग 5 से ही रिपोर्ट करते हैं. वो क्यों? एनीवन? 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 मतलब वी विल इंटरेक्ट ऑल दोज थिंग. आप लोग सिर्फ 5 से ही क्यों रिपोर्ट करते हैं? आई एम वेरी मच स्केप्टिकल अगेंस्ट माइक्रोबायोलॉजी रिपोर्टिंग. आई डोंट लाइक योर रिपोर्ट.
Sir, actually we report the antibiotic susceptibility according to the CLSI guidelines.
Okay.
So tier wise reporting करते हैं, first line, second line drugs.
अच्छा.
If first line is sensitive, then we avoid the.
So you mean to say you do cascading reporting?
Cascading.
लेकिन आप करते 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 मेरा पेशेंट तो मर रहा है ना, फीवर भी नहीं जा रहा है. You wish कि मेरा पेशेंट मर जाए.
नहीं.
और मुझे ये प्रॉब्लम है कि मैं पेशेंट को दे रहा हूँ सेफ्ट्रैक्सोन और आप सेफ्ट्रैक्सोन स्यूडोमोनास में रिपोर्ट ही नहीं कर रहे. आई एम वेरी एंग्री.
सर एंटीबायोटिक्स तो जो भी ऑर्गेनिज्म आइसोलेट आ रहा है हमारा, उसी के अकॉर्डिंग वी आर रिपोर्टिंग, सो दैट अननेसेसरी एंटीबायोटिक्स पेशेंट.
नहीं, सेफ्ट्रैक्सोन तो इंडियन गवर्नमेंट ने भी बोला है कि देना चाहिए स्यूडोमोनास के यूटीआई में, तो आप क्यों नहीं कर रहे? सेफ्ट्रैक्सोन से क्या नफरत है आपको? So these are the, I think you will be able to answer this question, which 20 years back all the clinicians were storming into our micro कि मेरा इसमें वेंकोमाइसिन क्यों नहीं है, फिर मैं देखा कि अरे ये तो क्लेप्सिला है. So would you like to, suppose now I am the angry clinician and storming into your lab, इसमें वेंको क्यों नहीं है, पेशेंट मर रहा है.
So the antibiotics that we report वो specifically एक particular organism के against act करे, उसी के according we give.
वेंकोमाइसिन में क्या प्रॉब्लम है आपने, why you have not reported vancomycin?
ग्राम नेगेटिव कवरेज उसका नहीं रहेगा इसलिए.
Okay, thank you. So these are the pertinent question that every day we face. Then any more bands that I have left, or anyone like to interact? Okay, ये बेंच पीछे वाला बेंच ये है, ये आपने MRA से बोला है तो सेफ्ट्राइक्सोन क्यों रिपोर्ट नहीं करा है रिपोर्ट में? Anyone? कुछ भी बोलो. We will talk all this thing after few session. मैं माइक्रो से बहुत खफा हूँ कि MRA से है और सेफ्ट्राइक्सोन नहीं है. पेशेंट को मेनिंजाइटिस भी है, मेनिंजाइटिस में तो सेफ्ट्राइक्सोन देते हैं, तो आपने क्यों नहीं करा? ऐसे this is also interactive. I can have eye to eye contact. हाँ हाँ, नहीं सेफ्ट्राइक्सोन में क्या दिक्कत है? आप लोग ही माइक्रो वाले ही तो बोलते हैं कि नीचे से ऊपर जाना है. अब आपको काउंटर करने के लिए आ गए ना मैडम? हाँ, इसीलिए आप तो उस हिसाब से हमें सेफ्ट्राइक्सोन को रिपोर्ट करना था MRSA में, और नहीं करा क्योंकि सर बोल रहे कि वेंकोमाइसिन ड्रग ऑफ चॉइस है ही, तो आपके पास अगर AK-47 है तो रिवॉल्वर का यूज क्यों करे? नहीं करना है. तो लेकिन है कि आप अगर एक आदमी को एयरगन से मार सकते हैं तो आप उसके लिए क्या न्यूक्लियर बम उड़ाएंगे? That's okay. हाँ हाँ, आप लोग ही तो जब एंटी माइक्रोबियल स्टीवर्डशिप या वो वीक होता है ना, क्या वीक, वाव वीक होता है, तो ब्लू कपड़े पहन के बोलते हैं कि एंटीबायोटिक को अब्यूज नहीं करना है. हाँ, तो मतलब यू आर काउंटरिंग योरसेल्फ. थोड़ी देर पहले बोल रहे थे, अच्छा चलिए एमोक्सिक्लेव दे सकते हैं क्या MRSA में? क्यों नहीं? मैं क्लिनिशियन हूँ. देखिए मैं क्लिनिशियन हूँ, एमोक्सिक्लेव है तो क्लेवुलिनिक एसिड जो बीटा लैक्टामेज एंजाइम में डिस्ट्रॉय कर देंगे, एमोक्सिसिलिन बैक्टीरिया को मार देंगे MRSA में. मैं क्लिनिशियन हूँ and I am very much angry with microbiology department.
Sir, it is the MRSA organisms, they are resistant to all the penicillin group and the first, second, third generation cephalosporins along with the monobacteriums. So when we know
तो
that
why क्योंकि आप हमें तो पता है ना क्लेवुलिनिक एसिड वो कर देंगे, डिस्ट्रॉय कर देंगे बीटा लैक्टामेज एंजाइम. And I am confusing you because I am a confused clinician, and these are the question that we are facing since मतलब I am in clinical microbiology since last 22-23 years and day in and day out. So how you convince him?
regarding use of amoxiclav.
एमोक्सिक्लेव क्यों नहीं दे सकते हैं MRSA में?
Because they are resistant to it.
So why they are resistant to it? मैं क्लिनिशियन हूँ ना, मुझे इतना पता नहीं है. मुझे MR ने समझा के गया है 2 मिनट पहले कि सर वी हैव फाउंड आउट ए न्यू BLI which is effective है इतना परसेंट इतना परसेंट इतना परसेंट, और आपका कॉन्फ्रेंस का स्पॉन्सर भी कर रहा हूँ बैंक्वेट. आप बोलिए. हाँ मैम. हाँ वो तो है. अब MRSA में मैं करना चाहता हूँ. हाँ मैं क्लिनिशियन हूँ ना, मुझे इतना पता नहीं है, मुझे कन्विंस करिए तभी मैं कन्विंस होऊंगा. Okay, so this is how most of the time clinicians storm into our conversation, storm into our lab, and they blame us that our reporting is not helping their treatment. So we have answer to many of these questions, which is the topic today we will be covering, and how we will be knowing at the last. I think this is also a Zaire batch, and I have not interacted with you, है ना. एंटीबायोटिक काम कर रहे हैं कि नहीं कर रहे हैं कैसे पता चलेगा, क्योंकि बहुत टाइम में ये होता है कि एंटीबायोटिक है और सभी सेफोटेक्सिम रेजिस्टेंट आ रहा है, तो अब है कि योर प्रोफेसर इज आस्किंग यू इज सेफोटेक्सिम इज वर्किंग. ये भी तो हो सकता है सेफोटेक्सिम ही खराब है, कैसे पता चलेगा.
Sir, actually I don't have idea about this.
Okay, anyone would try? Anyone? मतलब we will address all these questions later on along with some scientific ये anyone? अरे ज़्यादा से ज़्यादा गलत ही होंगे ना, but try to be as communicative as possible, which will help you in your academic field. This is not an exam where we will mark you. कैसे पता चलेगा? Anyone? कैसे करेंगे? नेक्स्ट प्रोफेसर पूछेंगे आपको.
We will use the ATCC strain,
Then?
and we will get the, because we already know the zone diameter that this organism will be positive, the ATCC strain for
हाँ
that cefotaxime. Yes.
ठीक है. तो सेफोटॉक्सिम का अगर सपोज आप ATCC इकोलाई दे रहे हैं, तो CLSI आई थिंक टेबल 2 में एंटेरोबैक्टीरियल्स की ब्रेक पॉइंट है, आप उसके साथ ये करेंगे, चेक करेंगे कि इसमें ज़्यादा सेंसिटिव है, इसमें इंटरमीडिएट है, इसमें रेजिस्टेंट है, एंड यू विल डू. ठीक है. देयर आर इफ्स एंड बट्स इन ऑल द क्वेश्चंस, एंड ऑल दिस थिंग दैट वी डू. जब हम लोग PG कर रहे थे तो इट वाज all those documents were not that accessible, but thanks to modern technology and piracy, now we are accessing most of the document, and we are approaching the truth in a proper way. So these are the induction question that we have started, and while doing it we will be knowing how to answer it. At the end we will recapitulate what can be a equally confident scientific answer that can help us scientifically. उसके बाद भी अगर क्लिनिशियन नहीं मान रहे तो you cannot help it, but so we will be starting with that. तो पहला क्वेश्चन क्या था? ज़्यादा सेंसिटिव कम सेंसिटिव. दूसरा क्वेश्चन क्या था? कैसे एंटीबायोटिक सेंसिटिव है या रेजिस्टेंट है पता चलेंगे. तीसरा क्वेश्चन था कि सेफ्ट्राइक्सोन क्यों नहीं दे रहा हूँ स्यूडोमोनास में, एमोक्सिसिलिन क्यों नहीं दे रहा हूँ स्यूडोमोनास में. चौथा क्वेश्चन था कि सेफ्ट्राइक्सोन और एमोक्सिक्लेव MRSA में क्यों नहीं दे सकते हैं, कन्विंस द क्लिनिशियन. एंड नेक्स्ट है कि हाउ टू चेक द quality of the disc. So for this there are hundreds of standards, as all of you are aware, but in Indian context nowadays most of us are following this CLSI, which is actually not one document but they have hundreds of documents. So today we would be focusing on M100 only, with some briefing about CLSI, but there are other document also. And what they do is actually they standardize all those breakpoints, they standardize all those quality control parameters, and they also standardize all the intrinsic resistance characteristics, and put different panels for different antibiotic, which we will discuss in detail. So over to Dr. I think all of you know Dr. Ketan. He has a book also credited to his name, but I would recommend you first complete the textbook that you are reading now, then start reading that book. Because I have seen few people start reading that book without basics of microbiology and fumbling here and there. So first and foremost, पहले 3 महीने में ही जो तुम लोग किताब पढ़ते हो basic वो खत्म करो, then read that book. Over to Dr. Ketan.
Thank you, sir. So, like sir very rightly told that we should understand, because this CLSI document or any these kind of breakpoint documents, these are actually different from our core clinical microbiology textbooks. So somebody has a question in his mind why we need these documents to be read by us. We have read microbiology, we know our microbiology, virology and other subjects. Why we should know about CLSI? The answer is nowadays AMR is increasing, we all know. And the way we have to fight AMR is through stewardship activities. Okay, so now there's a concept called as integrated stewardship, which has some pillars. One of such pillar is diagnostic stewardship, and one such pillar is antimicrobial stewardship. So these are the two components which are supposed to be handled by a clinical microbiologist. What is diagnostic stewardship? All the diagnostic assays which we perform in our clinical microbiology lab are all, so we define diagnostic stewardship as all the right tests are done by the right method, and the reports are, the correct report is communicated to the treating team in right time. This is how we define. So how we make sure that whatever test we do is the correct way, is through these kind of documents. Okay, these are guidance documents. CLSI is a document which helps us about interpreting the antimicrobial susceptibility testing, which is, I believe, is one of the most important investigation with a clinical microbiology laboratory does, which directly affects the treatment, especially the antimicrobial therapy. What drug we prescribe, it is directly being given to the patient, and patient is going to either get cured from that or may not get cured. Now this is one part. So this is what we call as diagnostic stewardship activity. Another part is, if you all give advice to the clinical team, like sir very rightly told, many a time either we go to the clinical bedside to the patient and give advices to the clinical team, or many times they call us, or while we meet in the galleries and somewhere, they ask us hundreds of doubts what they have regarding antimicrobial therapy. So until unless our knowledge is to that level, we know every crystal clear concept of antimicrobial therapy and these documents, we cannot be confident enough to tell them and explain their queries. So that is one of the very important reason why we, being a clinical microbiologist, should be very thorough in all the reasoning, why not, how, on all these documents, antimicrobials related things, to give us a confidence that we can talk to the clinical team and clear up their doubts. Okay, so one brief question I'll ask you. You all know about that we have so many documents existing in the market, which we use for interpretation of antimicrobial susceptibility testing. Can you tell me, anyone? I have mentioned 5 of such institutions. Can you name which of these documents you have heard of, or which you know make their documents for antimicrobial susceptibility testing related? What all you know of? Numbers? Do you know about number 1? Yes. What about number 2? You know. What about number 3? What about number 4? What about number 5? So the answer to this is these top 3. Unfortunately, so far NCDC and ICMR are very big institutes, but we don't have our own Indian clinical breakpoints for interpretation of antimicrobials. So we are still relying upon the Western literature. CLSI is an organization which is based in US, and it is pan-world. People are using their documents for performing antimicrobial susceptibility testing. Next is UCAST. This is European Union document. In Europe, they use UCAST. Outside world may also people are using UCAST. Third one is FDA. FDA is again a body which has clinical breakpoints available. Most of the breakpoints are same as CLSI because they both are US-based organization. But FDA also has lots of breakpoints which are not available in CLSI. So these are number 1, 2, 3 documents which we follow. Now CLSI is a paid document. We have to pay for it. We have to legally get it purchased from their website. But thanks to piracy, as sir told, we have illegal access of pirated versions of CLSI which we use. Not to be done, but still we have. Next comes to UCAST and FDA. UCAST and FDA breakpoints are clearly free of cost available in their website. These are their links. You can nicely Google it and go to these websites, read on these documents. These are freely available. CLSI we usually buy through a licensed price. Now today's discussion will restrict to primarily antibacterial susceptibility testing, and these are two godfather documents. We have CLSI M100 and we have CLSI M45. M100, most of the pathogen what we isolate routinely in our laboratory for performing the antimicrobial susceptibility testing of those. CLSI M100 document is well enough. But there are certain organisms for which we may not be getting them in CLSI M100. We may have to refer to another document which is called as M45. So these are top 1-2 document of CLSI for antimicrobial susceptibility testing. There are some supplemental documents also. We call it as M0 and M07. Okay, M02 and M07. What are these documents? How to perform. The 100 and 45 documents are more about once you have performed it, the susceptibility testing, either by a dilution or MIC based method or a disk diffusion method, how to interpret them, how to make sure that you did it correctly or you report it correctly, but how to perform those. For that information, these documents are referred to. M02 is based on, which gives us information how to perform disk diffusion, and M07 is a document which provides us information about how to perform dilution-based assays, MIC-based assays, be it broth microdilution, be it agar dilution, or any such assays. Okay, so these are another supplemental documents which, if you are good in reading, you must go through once. Now, first I want to discuss about interpretive categories, because our story starts with this. When we perform an antimicrobial susceptibility testing, we are supposed to give a report to the clinical team. Clinical team is not interested in how you perform the test. What they are interested in, what result you give in the AST report to the clinical team. That point is what we call as interpretive categories. We give the report as some interpretive category for that organism, for that antibiotic. So let's see a basic knowledge. So these are few terminologies. What you think, which all ones are included as an interpretive category? Any idea? I have something from A to F. Which all you feel that these are some sort of interpretive category, interpretive way how we can report our susceptibility testing in CLSI? Have you read it? Any idea? Anyone? ABC, correct. Anyone wants to add to anything to ABC? Anyone wants to add anything to ABC? Yes, E, sir added one. What about D and F? Yes, the answer is all of the above. All of these are some or the other interpretive category by which a CLSI AST report can be given. Okay? Okay, what about UCAST? What are the interpretive categories which exist in UCAST? Any idea? Because there UCAST and CLSI are different. And these are the report. Mostly we don't follow UCAST. Mostly, so we give our report based on CLSI, but at least the interpretive category we must know. What are the interpretive category what UCAST is having? Any idea? So it is, in them, the UCAST susceptible is equal to, in that we have seen susceptible, intermediate and resistant as two categories. Here, UCAST susceptible is actually called as number D, susceptible at standard doses. What is UCAST intermediate? I. susceptible at increased exposure, and resistant is resistant for UCAST. So when European Union people report susceptibility, they report it as CDE. These are the interpretive categories which usually they follow. A little knowledge on these things are important, because once you report, you must have seen a few susceptibility report from some remote colleges where they report it as plus plus plus. E. coli is the organism isolated, amikacin is 4 plus, gentamicin is 5 plus. Have you seen across those kind of reports? It is possible. Maybe I wanted to put an image of that, but I have seen plenty of reports where they report it as 5 plus, 4 plus, 3 plus. So those are wrong things. That's why the knowledge on interpretive category is very important. And when you even if you write correct word, like I wrote susceptible, or I wrote resistant, intermediate, susceptible, dose dependent, what is the meaning of it? You must give explanation. Best is to write the explanation in the comment box of your report, so that a clinician can read it and know what is I, what is S, what is R. If you can't do it and someone asks you verbally, you should be knowing it clearly to make them understand. So the first category is susceptible category. What we mean by susceptible? What is the susceptible thing? So susceptibility has two meaning to it. First is when we, in the lab, when we have tested that organism against that antibiotic, the antibiotic inhibited the growth of the bacteria. This is one part of susceptible, but that is not the whole part of susceptible. What is the second part of susceptible? Actually, if you give that antibiotic to the patient at a regular dose, at a standard dose, there's a high likelihood that the patient's infection will get resolved. Patient's infection will be treated. That is the main reason. When you write S, you're telling the clinical team that if you give that antibiotic in a standard routine doses, then this infection is expected. There's a high likelihood that this infection will be treated. What is the meaning of resistant? The resistance meaning is there. One thing is, in lab or in vitro, the organism is not inhibited by the drug. This is one part of the definition. But the other part of definition, which is more useful for the clinical team, is that even if we give that antibiotic is the highest safe dose. You cannot give the antibiotic in a toxic dose. But if you give that antibiotic in a highest safe dose, then even if that, there's a high possibility that patient's infection will not get treated. So giving high dose antibiotic in those resistant also may not work, okay? Then, so on one extreme of our report is susceptible, on another extreme of our report is resistant. But in between, there are some other categories. All those categories, like we talk about, like intermediate, like susceptible dose dependent, susceptible increased exposures, all those categories are something between susceptible and resistant. Meaning of these, we also have to understand, okay? So let's try to understand one by one, what are these categories and how we use it in our routine day in, day out. So one category is susceptible dose dependent. The meaning itself, the word itself suggests that the susceptibility is depending on the dose of the antimicrobial agent we are using. So when this kind of category of SDD is there, the meaning is, if at normal doses, if you give the antibiotic for a particular organism or infection, it is not going to work. But if you increase the doses, then there is a high likelihood that the infection will be treated. Increased doses can be at 3 levels. Increased doses can be increased doses can be at 3 levels, either increasing the dose of the antibiotic. Initially you are giving 500 milligram. Subsequently you give 1 gram or 2 gram. Dose is increased. What is the second way to increase doses? Increasing the frequency. You were initially giving OD once daily. You start giving twice daily, thrice daily. So this is increasing the frequency. And the third way to increase doses is to give as a prolonged or extended infusion. Initially you were giving the antibiotic as a 30-minute bolus. You charge a 100 ml normal saline and in 30 minutes you infuse it. If you increase the infusion time, instead of 30-minute bolus, you start giving it for 3 hours or 4 hours. Infusion time increasing also increases the efficacy of the particular antimicrobial agent, especially those who are time-dependent kinetics, especially who are beta-lactams. Let's sort it out for all the beta-lactam drugs. This works pretty fine. So these are the 3 ways how we can increase the exposure of drug in the patient and increase the chance of success of the antibiotic killing the organism. CLSI uses the word SDD, susceptible at dose dependent. The same terminology, almost same terminology, when used by UCAST, they use the term SIE, susceptible at increased exposure. So SIE is a UCAST term, SDD is a CLSI term. The meaning is exactly same, okay? Then comes intermediate. Intermediate is in a way like that, only that there is no evidence. SDD and SIE are evidence backed. CLSI and UCAS have worked on it, and they, through evidence, have proven it to be effective. Intermediate is like, yes, let's give a high dose, maybe work, maybe not work. Intermediate is that kind of category. We are not very sure whether increasing the dose or increasing frequency or infusion may be effective, not effective. We just are considering that to be a part. Then there is a CLSI, when you read CLSI, you'll find something like I with an inverted V over it. That symbol is what we call as caret, C-A-R-E-T. So it is what we call as I caret. Many times you'll see, if you read very carefully, you'll see I caret signs also. What is I caret interpretive category of CLSI? It means that a particular antibiotic is concentrated in urinary sites. It gets concentrated in the urine. So if it is normally in other body sites, non-urinary sites, if you give standard dosage, it may not work. But the same antibiotic, if you give for a urinary tract infection, it will work, because the drug in itself has a property to get concentrated in the urine. And so a standard dosage, which is, yeah, sorry, having some doubt. Yeah, SIE and SDD are exactly same. The meaning of this is, we have, I'll explain about the breakpoint. So if our report lands up in SIE breakpoint, the meaning is, if I give a standard dose, like whatever is the dose finalized, like for meropenem, piptas, it is, let's talk cefepime. So cefepime, the usual dosage is 1 gram TDS or 2 gram BD. This is a usual dose. If we give cefepime, which is actually in lab tested as SDD, the patient's infection will not get treated. But if we increase the dose, either from 1 gram we make it 2 gram, or from frequency of twice daily we make it thrice daily. So when we start giving 2 gram thrice daily to a patient, and that too over 3 hours, then that cefepime will act and will kill the infection. So increasing the doses of that particular antibiotic is going to treat the patient if it belongs in the SDD category. SIE is exactly same. It's only the... Yes. SDD and SIE are concept-wise same concept. Is the terminology what changed? CLSI, SDD, UCAST is SIE. That's it. So I caret you all understand. I caret is that particular drug is concentrated in urine. So in urine, standard doses is going to work. Non-urinary site mein, this is not going to work. Okay. So for example, suppose your clinicians ask that enterococcus infection mein ciprofloxacin you have written I caret. What should I do? Should I give high dose of ciprofloxacin? My answer will be, this is an example I'm telling. No, ciprofloxacin in urine, high dose is not required. You give normal dose, patient will get treated. Any other site infection, you have to give an increased dose. Okay, so this is the meaning of I caret interpretation. Let's try to understand what is this breakpoint thing. I've told you about categories, okay? Now let's try to, because in CLSI you have to read the breakpoints. So knowledge on the breakpoint is very easy. Two most common way of testing our susceptibility. One is dilution based, where we get some MIC values. Okay, and the other way to do the testing is when we do it by Kirby-Boas disk diffusion method, where some sort of zone diameter is the value what we get. These are the two ways commonly we do for testing a antimicrobial susceptibility testing. So let's try to understand. I'm showing this image. In this image, you can see this. In the top, I've written double dilution of the MICs, like 1, 2, 4, 8, 16, 32. These are doubling dilutions of MIC. This is how a MIC result comes. It comes as a unit is microgram per ml, and the values are in doubling dilutions. Okay, this is the MIC way how we get report when we do a dilution based or MIC based test. Zone diameter mein we get values 15, 16, 17, 18, 19 like that. So there is a one value, okay, of MIC or one value of a zone diameter which can differentiate it, the further finding into two categories. So just imagine 4 and 26 mm in this example. This is one value of diameter, zone diameter, or one value of a particular MIC. Anything which is less than that for MIC or more than that for the MM, they are all green. Green means these all means susceptible. Whatever is on the right side of it, they are not susceptible. They are not susceptible, okay? So a particular value of MIC or a particular value of zone diameter which can differentiate between susceptible and non-susceptible is called as susceptible breakpoint, okay? A one value of MIC and one value of zone diameter which can differentiate between susceptible category and non-susceptible category, green and non-greens, is what we call as susceptible breakpoint. Similarly, a value which can differentiate between the red ones, that is resistant ones, and not resistant ones. Okay, this value is what we call as resistant breakpoint. Okay, this is the meaning of breakpoints. One cutoff MIC value or one cutoff zone diameter which differentiate between green and non-greens, susceptible and non-susceptible. Zone diameter which can differentiate between resistant and non-resistant is called resistant breakpoint. Individually, if you use both the breakpoints simultaneously, we tell it as susceptible. Those which are on the right of the resistant breakpoint, we give them the name of resistant. What if something is between as susceptible breakpoint and resistant breakpoint, the yellow ones, that is what we call as intermediate. And all its names, intermediate, SDD, SIE, whatever you want to call, I caret. But this is the category which is in between a susceptible breakpoint and a resistant breakpoint. So this is how a category is given in any document, be CLSI and UCAST. Okay, so like this, I have kept an example. Can you see this? When you read CLSI M100 or M45, then each tables they have made, a breakpoint table we call it. Each table in the top, you can see table 2. This is a table 2 series. Whole 2A, 2B, 2C, like that they have a series of tables. All the table 2 series have breakpoints in it. So what we mean by breakpoint, just focus on the highlighted red block square. You can see they have written interpretive category and zone diameter breakpoints. S, SDD, I, R. Like for the first drug is, I don't know if it's visible to you, it is cefepime. You can see below S they have written more than equal to 25. It means if you test cefepime for any enterobacterials, if the zone is 25 or more, 25, 26, 28, the category will report it as S. If it is less than 18, it means 18, 17, 16 like that, report will go as R. And anything between that, 19 to 24, our report will go as SDD. The top of that is SDD. The same way, one more example I have pasted is cefotaxime and ceftriaxone. You can see the SDD column is blank because SDD doesn't exist in this. It has SIR. So this is how we read. These are zone diameters, and the green boxes ones are MIC ones. Same way, cefepime ke cases mein, if you see less than equal to 2 means 2, 1, 0.5, 0.25, any such MIC, the interpretation will go as S. More than equal to 16 is R, and in between 4 to 8 is SDD. So this is how clinical breakpoints is read. Same way, UCAST also have MIC ka, breakpoints and then zone diameter breakpoints. Most of the clinical breakpoint tables have, we read and interpret like this. This is how reading should be there. Okay. One component is this question if you want. Among this, can you pick it is easy. We have already discussed. The following are CLSI AST interpretive category based on clinical breakpoints except. It's an easy question, just now discussed. Yes, very correct. It is G because we have so far discussed A to F. What is this G thing? Wild type and non-wild type. I'll tell you what is this thing. Usually we have 3 types of breakpoints. The first breakpoint is what we call as epidemiological cutoff value, ECV, and second thing is what we call as ECOF, epidemiological cutoff. Same thing, ECOF, ECV are same. ECV is CLSI terminology, ECOF is UCAST terminology. Meaning is exactly same. Okay. What is this ECV and ECOF? When someone makes breakpoints, okay, the first thing what we do for making a breakpoint is doing MIC based studies, just lab based studies, nothing else. We do MIC based studies and we do MIC distribution plotting and all. I'm not going to details of that. Based on laboratory data, we know that these are the organisms which is, if have this kind of MIC, they'll have a resistant property in them. Those who are not, which are above something, they don't have resistant property. So a particular value of MIC or a disc zone diameter which can differentiate between having resistance and not having resistance characteristics, phenotypic, is what we call as ECV. So how ECV differentiates organism? Wild type and non-wild type. I've told you breakpoint. Breakpoint is a MIC value or a zone diameter which differentiate between wild type and non-wild type, is called as ECV. After we get ECV, we do some PKPD studies, we do some clinical outcome studies, and after that we get clinical breakpoints. That we have seen, whatever the previous tables were there, those were clinical breakpoints. So what comes first? What do you think? For a drug-bug combination, clinical breakpoint comes first or ECV comes first? Or anything can come first? Obviously, ECV can come first because it is the first you do lab-based study, then you do PKPD model study, and then you do clinical studies. Once the clinical study is finished, then you get clinical breakpoints. Once you finish your lab-based study, what you get is epidemiological cutoff. So it is the first to get. All new drugs may first we get is epidemiological cutoff, and subsequently we get clinical breakpoints too. Okay, this is very interesting. Okay, we are going towards a different part. We have finished our breakpoint, we have finished our categories. Let's see.
Dr. Ketan, एक minute, दो slide पीछे. Any doubt or दो slide पीछे? Any doubt अभी तक? Because of the time constraint, we have to move a bit fast. So मेरा जो पहला वाला question था ना, एक जैसे ये टेबल में ही देखते हैं कि कहाँ पे डिक्स MM का है?
सेफोटैक्सिम 26, 22.
सेफोटैक्सिम 26 से ज़्यादा होने से ससेप्टेबल है, और so मतलब सेफीपेम और सेफोटैक्सिम में ही पकड़ लीजिए कि एक का आया 27, एक का आया सेफीपेम का आया 32, तो सेफीपेम ज़्यादा सेंसिटिव हुआ ना, तो why you microbiologist don't say that ये ज़्यादा सेंसिटिव है, ये कम सेंसिटिव है?
Is it so? बड़ा है तो बेहतर है?
नहीं है ना, आपको दिखते आंखों से दिख रहा है, यू आर, इट इज एविडेंस बेस. आजकल हर कोई एविडेंस बेस वर्ड यूज करते हैं. हाँ हाँ हाँ, तो दोनों ही ससेप्टेबल है, बट एक का जोन साइज और भी बड़ा है तो और ससेप्टेबल होना चाहिए. So if मतलब we go to the what is the meaning of the ये susceptible means, I think it is written ना, वो वाला slide एक बार recap कर लेते so that our answer become more precise. back.
जैसे इसी एग्जांपल में अगर 23 सेफोटैक्सिम होता,
is antibiotic given for the infection in standard dose. अब है कि सेफोटैक्सिम का एक अपना डोज है, so that has nothing to do with this breakpoint that is being set up. अब ज़ेंटामिसिन 80 mg BD देते हूँ, सेफ्ट्रैक्सन नॉर्मली 1 ग्राम BD देता हूँ, तो that dose determination technically is a different thing from the breakpoint. So in that way, susceptibility में there is no such terminology as ज़्यादा sensitive, कम susceptible. Susceptibility का मतलब है कि स्टैंडर्ड जो डोज है उसमें वो इफेक्टिव होना चाहिए. इट डजंट डिफर कि बिगर द जोन इज और लेसर ये इज, दैट हैज वेरियस ये. और ये ब्रेक पॉइंट कहाँ से आता है? डॉक्टर केतन वाज ये, मेनी पीपल हैव दिस कंफ्यूजन. आई वुड ट्राई टू सुपर सिंप्लीफाई. मतलब दे विल टेक से 20 आइसोलेट व्हिच आर फाउंड टू बी, सपोज एक नया अक्सर होता है ना, आपके पास MR आते हैं और नया कुछ डिस्क लेके बोलता है कि सर आप उसका ससेप्टेबिलिटी कर दो, और फिर हम लोग एक रहता है कि वी टेंड टू डू इट, बट देर इज नो ब्रेक पॉइंट इन CLSI और FDA और UCAS और एनीथिंग. So how these are standardized? They collect some isolate where there is evidence that they are they have worked. Then they have collect some of the isolate where there is evidence that they have not worked. Then they determine कि Cmax क्या है. Cmax मतलब वो नॉर्मल डोज में देने में कितना ये होता है. फिर एक कार्ब बनाते हैं, बहुत सारे स्टेटिस्टिकल पैरामीटर्स, मतलब दिस इज ए हाइपर सिंप्लीफिकेशन ऑफ ए वेरी complex, that is not role of a microbiologist. That is why we should follow this document, because they do hundreds of study, FDA people do lots of study, share those data with CLSI, then they come up with a break point. So there is no such thing as ज़्यादा susceptible or कम susceptible for 99% of the cases. अब धीरे धीरे क्या हो रहा है कि we are left out with no antibiotic in many cases, where we need to tweak the MIC with some calculation जो डॉक्टर केतन बोल रहे थे PKPD का, but that is beyond scope of today's ये. देर आर ये कि रेजिस्टेंट आइसोलेट या इंटरमीडिएट आइसोलेट को भी एक ज़्यादा नॉन टॉक्सिक लेवल पे इन्फ्यूज करके हम ट्रीट कर सकते हैं, बट दैट इज बियॉन्ड द स्कोप ऑफ टुडे, सो वी विल स्किप दैट. सो दिस वाज द आंसर टू आवर फर्स्ट प्रॉब्लम, जो अक्सर क्लिनिशियन हमें ये करते रहते हैं. तो आंसर इज स्ट्रेट फॉरवर्ड, क्लियर, विथ कॉन्फिडेंस, आई टू आई कॉन्टेक्ट, कि ऐसा कोई बाडी नहीं है ज़्यादा ससेप्टेबल कम ससेप्टेबल. ससेप्टेबल मीन्स जो नॉर्मल डोज है, जो फार्माकोलॉजी की किताब में लिखा है, उस डोज में देने से ये काम करना चाहिए.
And in this situation, many times you will also face, and you will keep facing what sir told. The drug company or the pharma company will come to you with some molecule. They'll say, this is wonder drug, sir. You test, start susceptibility. Our clinicians are ready to use it. You just write susceptible or resistant, they'll use. But until unless a defined breakpoint by a standard body, which we have seen, FDA or CLSI or UCAS, come up with a clinical breakpoint, patient uses report में, you will never test and report. Never. डिस डिफ्यूजन कर दिए, एक डिस्क ला के पकड़ा दिया और वी डू इट टेस्टिंग, एक बड़ा जोन आ गया, बहुत ससेप्टेबल है, रिपोर्ट कर दो. लैब में, रिसर्च मोड में, PhD थीसिस में, whatever we do for Ayurvedic drugs also, that is fine. But when it comes to patient uses, that patient is going to be treated by that molecule, until unless a breakpoint is not given by a standard body, there should not be a testing, there should not be a reporting in a patient report, period. Okay, this is very interesting. Let's see, it's a very easy topic also. I expect you all to reply to it. So just a scenario is in a day-to-day microbiology lab, you got a positive flagged blood culture bottle. We did the grams from the bottle. We got gram-negative bacilli. Then we cultured it on blood and MAC. And we got one NLF oxidase negative growth. Then we performed our routine susceptibility testing by disc diffusion. And this is the picture we get. This is the picture of the plate what we got. So what do you think? Which of these drugs, I know the visibility is little poor, but try to read and see which of these options are correct. What are the susceptible ones you think, and what are the resistant ones? So which option you think will be better? You can read the name of the antibiotics on the image, MHA. So which options you think is correct? Anyone from that side? Or from the back maybe? Which looks correct? Any idea? One answer I got from this side. Yes, why don't know? Yeah, exactly. Zone is not measured. I gave you the measurement. Now what's the answer? Okay, you need CLSI, okay. But still, two, ones are told two. What about others? Guess. You must, with some recall you have, maybe. Either one or two, maybe. Correct? Agreed? One maybe, one looks more better. Okay. The answer is still don't know. Why? Why? We don't know the organism. LF can be hundreds of things. And for every organism, there is a different breakpoint. So until unless you know the organism, there is no way you can report or read a susceptibility plate. No way, never possible. So you must find out the organism name before you even think of reporting. Okay? So organism name identification is the most crucial thing before you even begin reporting an AST plate. Okay, let's go with this second scenario. Same, this time we know the organism. The organism ID came as Pseudomonas species, but somehow my lab is not equipped with speciating the Pseudomonas. So we got the ID as Pseudomonas species. Same way I put the AST plate, I got this. So what do you think now? Exactly, zone sizes are not there. Take the zone sizes. Now guess, I thought of putting a AST breakpoint also here for your easy go, but still try to go with it. C, correct. Anyone else? There are two messages to it in this. First and the most clear-cut message is don't know. Why? I'll explain, give the explanation. The reason is because breakpoints of CLSI are not only organism specific, it's the particular level of identification of the organism. I'll discuss that level of organism. The CLSI Pseudomonas breakpoints are for Pseudomonas aeruginosa, only aeruginosa. You can't use that breakpoint for any other species of Pseudomonas. This is one example. I have list of subsequent slides. So organism ID is not only important, organism ID at a particular level as required by CLSI or UCAST is important. Okay? Now this is comparatively easy. So ID is Acinetobacter species, and let me give you zone diameters. Can we do this identification? Acinetobacter species, we didn't found the species name. We were not able to do it. Acinetobacter species, like Pseudomonas species in the previous example. Can we do the reporting or not? Can we do or can't we do? Yes or no? Can we do? Yes. How many? We can't do it. We have to speciate it. How many? We have to speciate. Anyone? Without species also we'll report. With species only we can report. Both sides. At least raise a hand. We'll not fine you if you wrongly raise your hand. The answer is for Acinetobacter we can do without species. That's why I told proper species level knowledge you have to have. That for what organism, what level of identification is a must. Can I do before that or I have to reach that? So it's not about ID, it's about level of ID which is very crucial. So before I go to the level of ID, one more thing is important is which document to refer to. So can we try the first question? So I have Vibrio species. One answer came as M45. Somebody wants to contradict? I don't think that answer is correct. But anyone who also has opinion same as me? Vibrio species I have got in my lab. I want to test susceptibility. Which document I lift from my Almira and start reading? M100, correct? Everybody agrees? M45, correct. So which document has which organism is also a very important thing. अरे इसमें तो दिया ही नहीं है, पूरा organism देख लिए, कहाँ है? Because that organism is not at all part of that document. So which document has what organism? You have to know. What about Neisseria gonorrhoeae? Which document? 45, correct? 100. So knowing the organism which exists in which document is also a very crucial part. So once we read this, I'm telling these points because we can't teach you inline CLSI in these kind of short period. But what are the important things we have to look forward in order to utilize CLSI? This is the way we read it. Now I'll come to the levels. What are the levels we read? So you go in the table 2 series. These are the table 2 series where breakpoint tables are given. This is M100 ka screenshot. What are the levels which we have? Okay, first table is for enterobacterials except Salmonella Shigella. Next we have a table for Salmonella Shigella, Pseudomonas aeruginosa, only aeruginosa. Okay, then we have Acinetobacter species, any species of Acinetobacter. Then we have Burkholderia cepacia complex, all the organisms in that complex together. Steinomaltophila, other non-enterobacterials. I'm telling you what this category is. Then similarly we have different names like Haemophilus. Breakpoint is only for influenzae and parainfluenzae. Which is not influenza and parainfluenza Haemophilus, you cannot use this breakpoint to identify. Okay? And this is the table where some important organisms which are listed in M45. If you ask me top 1, 2 of this M45 is Aeromonas and Vibrio. These are the commonest we keep getting in our labs. For both those, we refer to M45 document. Few others are also there, Burkholderia pseudomallei, if you get Brucella, you get. We know these, though this you have to open the document and see what are the organisms listed in M45 for use in susceptibility testing. Now the levels I'm talking. Different organism has different levels. Those who are okay at gene level are Salmonella, Shigella, Acinetobacter. No need to speciate it. If you don't know the species, you can still use the interpretive breakpoints. Species level is a must में pneumococcus. You have to know it to be Streptococcus pneumoniae. Streptococcus hai. You can't use the breakpoints. You have to know it is Streptococcus pneumoniae. Specific species level, like for example Pseudomonas. You need not speciate it totally. You just have to find out it is aeruginosa or non-aeruginosa. The breakpoints are decided on that. If it's aeruginosa, different table. If it's non-aeruginosa, different table. That much knowledge is enough. Accurate species, no need to identify. Same goes for Staph aureus. Aureus or non-aureus. That much differentiation is enough for you to use breakpoints. Haemophilus mein, whether it is influenzae, parainfluenzae or something else. This much of differentiation is enough. Vibrio ke liye, Vibrio cholerae or non-cholerae. Among non-cholerae Vibrio, it can be anything. For susceptibility testing interpretation, it's not required. But knowledge on whether it is cholerae and non-cholerae is a must to utilize the breakpoints. So this is the levels. Then some are at complex level, like for example, beta hemolytic streptococci. They have a whole group. So everything which is under beta hemolytic streptococci, one table. Everything which is viridans streptococci, one table. So you need to know whether it's Streptococcus mitis, mutans, or anginosus or what. If you know it is viridans streptococci, you can use breakpoint and interpret. Okay. So this knowledge at what level, what interpretation is very crucial for us. Now the second part is what sir very correctly discussed is intrinsic resistance. Which organism is intrinsically resistant to it? So we have two levels to report AST. The first level is intrinsic resistant. If that particular drug is intrinsically resistant to a organism group, we'll never report it. We have to put a note in the down. This organism is commonly intrinsically resistant to these drugs. What is the second point? Once you remove the intrinsic resistance once from your report, the next level is for which breakpoints are available or not available. It may not be intrinsic resistant, but the breakpoints are not available, we'll still not report it. So only those drugs which are not intrinsically resistant and for which breakpoints are available in the correct document, be CLSI, be UCAST or be FDA, only those we report in a patient report. These are the two important filters we have to put.
That brings us to the second or first question that I asked. I am till he finishes his lecture a skeptical clinician who do not like microbiology report because they give very short amount of antibiotic and market is full of hundreds of antibiotic. So one answer is because of the intrinsic resistance. You just Google and paste it if because CLSI is a I think all of you are having into hundreds of microbiology groups, so you might have it. If you don't have it, just Google it, then find that these are intrinsic resistant. Then answer कि ये जो है ना vancomycin क्लेप्सिला में ग्राम नेगेटिव में इंट्रिंसिकली रेजिस्टेंट है. नाउ जो सेफ्ट्रैक्सोन क्यों नहीं दे रहे हैं? गवर्नमेंट का एक डॉक्यूमेंट में दो आया था, बट वो इंट्रिंसिक रेजिस्टेंस में ही है. सेफ्ट्रैक्सोन स्यूडोमोनास में काम नहीं करते. तो ऐसे ही देयर आर hundreds of antibiotic intrinsically resistant to 100 of individual bacteria. So because of which our report is less. Then my second question was, you would be bringing MRSA later, or
Yes,
I
sir.
should?
I'm bringing, sir.
Okay, okay. So this is one of the answer. Then we will be coming up with more answer in coming slide.
Okay, like for example, most common organism what we get and we have a fight on that is Proteus. Nicely, you'll get a blood culture positivity, and where Proteus vulgaris is isolated, you'll try to convince that, sir, it is a susceptible isolate. You can give ceftriaxone, you can give this, that. Then the clinician will ask, no, I'm talking from ICU, you know, now I'm medical ICU. And in medical ICU, when the patient is sick, we only give colistin and tigecycline, wonder drugs for us. And then you say, sir, but in this patient it will not work. Why not work? Colistin and tigecycline can even bring back the dead patients. The answer is because they are intrinsically resistant. So if you know this information, then you'll straight away talk about that, sir, it is intrinsically resistant. Even God cannot come on this land and make sure that tigecycline work on Proteus. So if we have this knowledge, and we as a clinical microbiologist go to clinical microbiology round or AIIMS round and talk in this confidence, evidence-based talk, then they'll listen to us. If we'll be beating around the bush, so, oh, sir, give small antibiotic, no, why to give big antibiotic? He'll not be convinced. The answer is straight. It's not big antibiotic, small antibiotic. It is not going to work. Intrinsically resistant. Gram-negative sepsis में Vancomycin you're giving, it's not going to work. Nothing is going to do to the patient.
So ये कोलेस्टिन जो है आजकल एक दो रेजिस्टेंस आने लगे हैं, लेकिन 10 years back one day all the ICU people came कि आपने रेजिस्टेंट कराए because that was a Proteus, but patient was already, because why he developed Proteus infection, because he was on colistin for a very long time, and eventually it was a क्या बोलते हैं mutant
Yes, mutant selection.
Selection that happened, and eventually it infection. So knowing this intrinsically resistant thing against commonly used antibiotic is very much important. So all of you should put one print of intrinsic resistance for the common antibiotic which our clinician prefer, and our answer should be thorough with the intrinsic.
Okay, one question I'll ask. How many of you still use conventional biochemical for identification of organism? No automated system, or automated system but rarely used, sometimes used, kind of. Okay, few only. So most of have automated system and do all the ID with automated system. Never use a biochemical, never touch a biochemical.
हमें तो कॉलोनी देख के पता चल जाता है ये कोला है, सूंघ के पता चल जाता है ये स्यूडोमोनास है, दूर से देख के पता चलता है ये प्रोटियाज है.
So why?
Because I have worked 30 years in microbiology.
So why I'm talking about this is enterobacterials. Even single biochemical can change your ID. Okay, and I'm talking only about AST aspect of it. You should also know that which ID change is going to affect me patient treatment wise, AST wise, or which ID change is not going to be affecting my treatment part. If I have an ID confusion between two organisms with one biochemical doubtful, which can affect the AST interpretation, I'll be very cautious. Like for example, this is what I call that intrinsically resistant spectra. There are certain enterobacterial organisms which have similar kind of IR patterns. Okay, so if you can get confused between them, it's okay, it is acceptable. But those which have a different IR spectra, you can't, like in this image, this is an IR table. As you see, those blue I have highlighted. So those blue groups are which have similar IR pattern. Like if I get confused between Klebsiella aerogens and Enterobacter cloacae, whether it is going to affect my susceptibility pattern ka report, the answer is no, it will not. They have exact same IR pattern. So what will exclude for Klebsiella aerogens will definitely exclude for Enterobacter cloacae. So if I get confused between them, I don't bother. If I get confused between Klebsiella aerogens and Klebsiella pneumoniae, blunder. They have totally different IR pattern. So you may mis-ID it as Klebsiella pneumoniae, report a drug which the organism was actually Klebsiella aerogens, and you reported a IR antibiotic. So this knowledge of IR spectrum, especially in enterobacterials, is very crucial. If you use a conventional biochemical system, make sure that you land up in a diagnosis or organism which is in a same IR spectra, you cannot report anything out a spectra. If you report, if you still not able to identify and you have to report, make sure you remove all the IR for other spectras also. Like if I am not having a confidence of Klebsiella aerogens versus pneumonia in my patient, yes sir. Klebsiella pneumonia and Klebsiella aerogens, I'll report it as Klebsiella aerogens and remove the IR of aerogens. Better to report a susceptible, safe drug to a patient than to play around with pneumonia and by mistake report a resistant ones. Okay, so this is how I'll do if I have a limited resources, confusing ID in enterobacterials. I'll go for a higher IR drug as a report, not as a lower IR drug, to avoid patient being treated with a wrong drug. So this IR spectrum enterobacterials for conventional biochemical is a very important thing.
I will just, last slide please, I will just add 3 points. Just because he was so humble, so he did not cut my word कि ये जो है ना कि मेरा इतने साल का माइक्रोबायोलॉजी का एक्सपीरियंस है, ये doesn't hold true. I thought he will cut my, that is why I pitched that. बहुत लोग होते हैं, अरे मुझे ये स्यूडोमोनास है, या क्लिनिशियन भी है, ये टीबी का पेशेंट है, अरे डॉक्टर साहब आपको क्या है, फिर अल्टीमेटली कुछ अलग ही निकल के आते हैं. So this kind of over confidence is bad. साइंस अभी भी साइंस ही है. एंड नंबर 2 पॉइंट, ये आई थिंक जेपी के लोग हैं, मुझे थोड़ा कमीशन देंगे, ये उस बुक में भी मिलेंगे, तो इसका एक फोटो को भी अपने लैब में लगा सकते हो. और नंबर 3, ये आईआर जो बोल रहे हैं, फ्यू पीपल माइट बी ट्राइंग टू डोजिंग ऑफ आफ्टर गुड फूड. आईआर जो बोल रहे हैं इंट्रिंसिकली रेजिस्टेंट बोल रहे हैं, मतलब बिकॉज ये ऑर्गेनिज्म ये है तो वो एंटीबायोटिक उस बैक्टीरिया में काम ही नहीं करेंगे. ओके,
यस सर.
But what I understand is that in this intrinsic resistance, this concept came from previous research.
No, it's the actual inbuilt property of the organism. Like suppose organism, the drug acts on a molecule B, and that molecule B is not present in that organism. So it is not going to act. It has a property of acting on B only.
अच्छा अच्छा, तो मतलब देन आई हैव टू सिंप्लीफाई एज पर ईयर ना. जैसे होता है कि एक बैक्टीरिया का नाम, प्लीज सिट डाउन, एक बैक्टीरिया का नाम है माइकोप्लाज्मा, उसके सेल वॉल ही नहीं है, तो कोई भी एंटीबायोटिक जो सेल वॉल पे एक्ट करेंगे काम नहीं करेंगे. तो ऐसे ही ग्राम पॉजिटिव की सेल वॉल थोड़ा अलग है, ग्राम निगेटिव की सेल वॉल थोड़ा अलग है, इसीलिए वो काम नहीं करेंगे. ऐसे ही कुछ है कि कुछ पर्टिकुलर रिसेप्टर में करते हैं, अगर उस बैक्टीरिया में वो रिसेप्टर, so there are hundreds of reasons because of which some बहुत सारे ऑर्गेनिज्म बहुत सारे एंटीबायोटिक से intrinsically resistant होते हैं.
Thank you, sir. And one more thing, what I understood is that when we are putting this AST in that lawn culture plate that is diffusion, so we have to exclude these antibiotics and put the panel.
Yes, yes, absolutely correct.
Yes and no. Yes इसलिए because the intrinsically resistant. No इसलिए क्योंकि if we are doing it manually, so on मतलब क्या होता है कि first day we put the culture, second day there is growth, so then parallelly for third day we put the AST and we put the ID, which is actually 2 separate set of activity. So third day we are knowing the antibiotics, so on second day
exactly the topic of discussion in the next slide. Exactly this topic only comes in the next slide.
Okay, then
so that's why I'll just tell you some must do's before or while we do a AST thing. First thing is very important is don't give bada zone chota zone, big zone small zone. Don't read. If you read a or AST plate and we don't have a measuring scale or a vernier caliper in your hand, absolutely rubbish. You can throw your plates and go home. Take a leave, maybe one year or something
मेरा
like that.
30 साल का experience है.
So, yes, exactly. In this slide only I'll say you, human brain कर ही नहीं सकता है I से zone mm का estimation. When I will give you one table example in the slide, you will say agree with me. I'll have a table in that. So never ever trust your eye. 22 ही लग रहा है मुझे तो. Never ever. स्केल 5 रुपए में आता है और 5 टेबल पे 25 रुपए का इन्वेस्टमेंट है, ठीक है. यू आर नॉट, दिस इज ए एडवांस लोग, अमीर लोग ऐसे करते हैं. दिस इज वर्नियर कैलिपर्स, ये 300 रुपए में अमेजन पे अवेलेबल है. तो आज के डेट में 300 में तो कुछ भी नहीं मिल रहा है, पर ये अमेजन पे मिलता है 300 रुपए में. तो यू कैन हैव ए वर्नियर कैलिपर, इट इज डिजिटल वर्नियर कैलिपर, 300 इन अमेजन. सेट करके खुद से बता देगा. इवन 1 mm का डिफरेंस कैन चेंज योर इंटरप्रिटेशन. If you can't afford a 300 rupees vernier caliper, then go for 5 rupees ka scale, but don't skip that, okay? If some scale is lost, go in the evening, buy a scale and then start the reporting, okay? One part. When you note down, most of you will be reporting the, doing the reporting, writing in the register first and then putting in the patient's report. While you do in the report, always write the zone diameters. Don't write susceptible amikacin, gentamicin, ceftriaxone, resistant this. Write in the bracket 22 mm, 25 mm, okay? Writing the zone diameter is very crucial for subsequent analysis, very crucial. The last thing, next thing is
for microbiological interpretation.
For microbiological,
we are having clinician also among us, then they might complain ki why you are not
don't write in the report. Yeah, if you understood that, please, sorry, I was not much clear. Writing in the register, the working register of microbiology department. Don't report zone diameters in the patient's report, please. That much transparency is lethal.
If we have a clinical people who can understand the meaning of everything.
Yes, I'll just, we have, yes, we'll have that.
Okay.
Okay, the next part is, what sir was asking is how to make sure that the IR antibiotics are not tested. Not possible. What you have to do is, you have to create panels. What you have is, you have a growth on McConkey, you have a growth on blood agar, and then you are going to put ID and AST simultaneously. If you are rich enough, you'll get MALDI. You'll get MALDI ID in another 30 minutes, and with ID, you'll put specific panels, where IRs you can remove. But most of the places, it's not possible. So what we do the ID and AST simultaneously. What we do in that case, we have to create a panel of antibiotic which will test based on the colony characteristics. We have a LF panel, we have a NLF oxidase negative panel, we have a NLF oxidase panel, positive panel, GPC cat positive panel, GPC cat negative enterograms panel, and GPC cat negative strepto type of panel. Strepto panel mein you can put all the antibiotics for all the strepto, beta hemolytic, viridans and everything covered. Okay, these are the panels you must create. Prepare a panel stuck on the wall of the where AST is done. This is very important. Now, breakpoints. Every time CLSI book is this 450 pages. You cannot sit with 450 pages on a daily basis in your bench reporting. Plus, you can't remember the zone diameters also. What you have to do is, you don't CLSI for each organism, we have 60-70 antibiotics. Whether you put 60-70, no. You take hardly 12-15 drugs like that. 2 plates of MHA, 6-6 or 7-7 each. So whatever you test in your lab, for that, you write down on a piece of paper, MS Word, take a printout of that and keep it handy at each bench. Divide it into Enterobacterales, Salmonella, Shigella, and other organisms tables. Include only those 12-16 antibiotic which you actually test in your lab. Take a printout, multiple printouts, each table, respi, urine and all those tables, keep that handout. Always report with that handout. Never skip that handout. There is a reason why I'll show you some example. This I'm talking about meropenem. Meropenem is drug which is tested for gram-negative में Enterobacterales, Pseudomonas aeruginosa, Pseudomonas species के लिए there's no have breakpoint. This diffusion, Acinetobacter and Burkholderia cepacia. Just see, one meropenem for just 4 organisms has 4 zone diameters, 23, 19, 18, 20. I have not kept the rare organisms here, like Aeromonas, Vibrio and all other organisms. So how, for one drug, you have 6 zone diameters. Is it humanly possible to remember it for 16? You can remember meropenem at 23, but that 23 is for Enterobacterales. It's not for Acineto, it's not for Pseudomonas, it's not for Burkholderia, it's not for other organisms. So humanly not possible to remember zone diameters. If we claim that, we are giving a fake claim and we are doing errors while doing the reporting on a daily basis. Okay. Next point is, so I told you to no memory recall based things to be done. Why we need noting down? Very easy, because breakpoint keep changing. These breakpoints, they keep changing. Every year, CLSI comes up with a fresh breakpoint. Many times you start reporting in January, and by March, you'll get a CLSI in your hand and the breakpoints are changed. Re-evaluation for anti-diagram preparation or any such data entry, HUNIT platform and anything, these breakpoints or zone diameters will be required by you. So, for this anti-diagram preparation primarily, we need zone diameters to be written. For your seniors to verify your errors also this is required. Okay, so it's a must habit. Okay.
I will just super simplify something, because we have a bigger audience and many people still answer कि ये antibiotic susceptibility मतलब when we interact with PG ये AST कहाँ से मिला सर वो वहाँ पे चार्ट लगा हुआ है वो चार्ट कहाँ से आया सर हाई मीडिया का है नाउ मतलब that answer is नहीं मतलब can we rely on that answer and that हाई मीडिया का जो प्रिंट आउट है और आजकल टाइटन और बाकी लोग भी प्रिंट आउट दे देते हैं नीचे CLSA लिख देते हैं फिर बोलते हैं देखिए ना सर CLSA लिखा है but when we have cross-checked it with the practical it is also having various antibiotic for which neither CLSI nor UCAS is having. So high media based breakpoints are not high media नहीं मतलब any कंपनी बेस्ड ब्रेक पॉइंट को फॉलो करने से ये सब प्रॉब्लम आता है तो बेस्ड इज CLSI अब है कि व्हाट डॉक्टर केटन इज सेइंग इज द वेरी एडवांस लेवल बिकॉज 2025 हो सकता है किसी के पास नहीं है तो आप 2024 वाला यूज कर लीजिए या यू कैन आस्क हिम पर्सनली इफ वी कैन हेल्प यू टू हैव वन बट दैट कैन नॉट बी आंसर कि सर हाई मीडिया का वो है और हाई मीडिया तो CLSI का रेफरेंस दे ही रहा है क्योंकि उसमें बहुत सारे इश्यूज है तो PG में या डेली रिपोर्टिंग में बोथ आर नॉट द आंसर कि सर टाइटन बायोटेक ने मुझे ये दिया है और वो CLSI का है एंड व्हाट इज ब्रेक पॉइंट इज क्लियर कि ये माइक्रोबायोलॉजी के यूज के लिए है वो डोज के साथ डिफर है मिलजुल नहीं है okay
now I'm coming to a question what sir has asked long back ki why some antibiotic why we report 7 or 8 antibiotics why not report 20 antibiotics so one part of the answer was we don't report IR drugs you don't need to just write the IR drug and report resistant you say that what if my gram negative panel is also having vancomycin I always remember to write R in it this is going to corrupt your clinical team, give a wrong impression to the clinical team. If you write an IR drug and write resistant to it, he'll believe that for this organism it is R. Maybe sometime I'll start seeing S also here. So IR should not be part of the panel, it should be removed. Many private labs do like that. If they don't rectify, they have a common 50 antibiotic panel and doesn't matter what comes, IR may they keep resistant, I agree. They don't report, but that practice also is a wrong practice. There should be a customized report where IRs has to be excluded. The clinician should know that this, when you write resistant means in this organism is resistant. It is ultimately it can work in other same organisms. So don't mention. And the another part is what we call as cascade reporting. Okay, you test for many, but you report few in order to save the antibiotic, save the higher antibiotic. That cascade is a concept which we have been teaching for a long. But now last year onwards, CLSI has brought that concept also. So they have used cascade, that there is a term called as tired term. Okay, I'll just skip that, I'll explain you the tires. So tire is basically, what is cascade reporting? Cascade reporting is, suppose I have tested for 15 drugs, not all drugs are similar. Some drugs have more effect, we preserve them for a more serious kind of infection like ampicillin versus colistin. Colistin is a good drug, but it has to keep for some more drug-resistant organism. We can use amoxiclav and other simple oral or easily available drugs on less severe patients. So similarly, we have to categorize the drug into various categories. The orally available or the small narrow spectrum drugs as first line drug or tier 1. Then some in the tier 2 or second line drug. then some in tier 3 or third line drug, and the restricted lines as tier 4. This is how, so you name it as first line, second line, third line, fourth line. You name it as tier 1, tier 2, tier 3, all are cascade reporting. If some drug is susceptible in tier 1 or first line, you report those and don't report tier 2, tier 3. But you have to make sure that that particular patient may, the susceptible antibiotic can be given, and minimum 2 choices you have to give. 2 class of drug you have to give. 1 class of restriction of cascading is not recommended, so that the clinician also have some freedom to choose among that classes. You report quinolones, they are not comfortable giving quinolones, so you say give 1 quinolone, maybe 1 beta-lactam options, they can choose among this. So cascading is not a strict cascading. 2-3 classes at least must be available in that cascading, but still you hide back your higher gen antibiotics. So this tiering is what CLSI is recommended. You can modify it subsequently. Tier 1s are which are primarily tested, day 1 of testing, and you report also on full. Tier 2 is you test primary, but you report selectively. Tier 3 is again which you test primary and do reporting selectively. Why I'm telling primary testing? Because suppose I have tested for 6 antibiotics on day 1. On day 2 I came to know that all 6 are resistant. If on day 2 I'll put another 6 ka testing, the result will be available on day 3. Suppose on day 3 also we get all 6, next 6 are resistant, I have to wait for another day 4 for getting the new ads. So all testing has to be done on day 1 only. Subsequently, I'll hide back the report based on how susceptible or how resistant the drug is. So testing has to be primary, but reporting has to be selective. This is the concept of cascade reporting. But there are some tier 4 agents which we test only a clinician's access. The most commonest example of tier 4 agent is, say, ceftazidime avibactam or ceftazidime avibactam astronam synergy. So these are not routinely tested. If your lab is, your institute is using those drugs for patient and your clinicians ask for it, no, for this antibiotic, everything is, I can't use, can you do this susceptibility testing? So on request testing is what we call as tier 4, okay? CLSI has given us nice tables. These are table 1 series in CLSI where they have done tiering. But this tiering is based on US parameters, United States. This may not fit in properly with us. So what I did is, I make this scribbling on the CLSI is, I made my own tiering based on CLSI. So this is my tier. When I wrote all those red colors, red ones, 2, 3, 4, you can see. So this is tier recommended by CLSI. I have modified for my own purpose. I made my own tier based on Indian scenario, based on my resistance pattern. So what CLSI writes, you may not want to follow it. Create your own tier based on your resistance pattern, decide on what all can be 1, 2, 3, 4 in your scenario, take a printout and paste on the wall. Have a notice board in microbiology lab. You keep all this pasting these things so that your department knows that what are the tiers we have to report. Okay, so this is very crucial.
This is also crucial and थोड़ा सा problematic भी है with respect to the clinician, because you are reporting one and organism and you are reporting only 2. So for that you have to be pragmatic and readily available to the clinician. So what method we have approached is that for report, मतलब हम लोग जब report करते हैं restrict करते हैं तो नीचे लिख देते हैं for higher in antibiotic microbiology lab may be contacted at CUC number XXX. वो report में ही रखते हैं, then they communicate. So वो जो mistrust और वो है वो build हो जाता है कि these are the reason. And nowadays we have enough interaction तो वो mistrust hopefully नहीं है.
Then there is a concept called as equivalent agent. This is a very interesting concept. Many times in your report it is written as colistin is susceptible or intermediate. Then your clinician give you a ring and tell that, but I am not using colistin, I am using polymyxin B. Give me susceptibility of polymyxin B. You reported ceftriaxone and your pediatrician called that, no, I don't use ceftriaxone. I give babies my cefotaxime. Give me cefotaxime ka susceptibility. So here comes the concept of equivalent agent. What is the concept of equivalent agent? There are certain drugs, a set of drugs where result of one can be safely and reliably predicted as a result of the other. Like one such classic example is ceftriaxone and cefotaxime. If your ceftriaxone is susceptible, your cefotaxime will be susceptible always. If your ceftriaxone is resistant, then your cefotaxime is also resistant. The reverse also is true. If ceftriaxone susceptible, always ceftriaxone susceptible. So reverse, the result is S and R both के लिए valid. One drug S, another will be S, and one drug R, another will be R, and it is bidirectional. A to B, B to A. So bidirectional susceptibility of prediction, this is what we call as equivalent agents. Colistin polymyxin B is an equivalent agent for CLSI, ceftriaxone, cefotaxime, and there are certain other examples, macrolides में azithromycin, erythromycin. So this is the table. When you go through the document CLSI, you will find a list of equivalent agents. So if your clinicians ask to you, or the treating team asks to you that we want this, what you have given is not what we need, you can tell that, sir, this is same, it is equivalent agent. You can very reliably use polymyxin B with a susceptibility result of colistin. That is how it goes. Then there is a term what we call as surrogate agent. What is surrogate agent? The same concept. One drug tested in lab, and you predict the susceptibility of many drugs, one or many drugs with that. That is what we call as surrogate agents. Only difference between equivalent and surrogate agent is it is not bidirectional. It is unidirectional. You test for one drug and you predict the susceptibility of many others. But reverse cannot be do. You cannot do on this side and predict susceptibility. What sir asked is this one. This is the most classic example what we talk is cefoxitin in staph aureus. This is what we call as surrogate testing or predicted susceptibility. I'll tell you what are the common and why the reason. The question was why we consider that part of. I'll come to that. So this is the list. The most important is cefoxitin in Staphylococcus aureus. Okay, I'll come to this later. So, let's discuss. Okay, I'll just briefly tell you about staph aureus. I think it's in some slide, but because we are discussing that, let's finish this. We do testing for cefoxitin, desdiffusin, MIC, or we do testing for oxacillin MIC based method for staph aureus. With that, we can predict susceptibility of many beta-lactam drugs. Like if oxacillin is susceptible or cefoxitin is susceptible in staph aureus, it means the BLBLIs like amoxiclav, piptas, cefiprozone, sulbactam are susceptible. It also means that anti-staphylococcal penicillins like cloxacillin, dicloxacillin, flucloxacin, nafcillin are susceptible. It also means that carbapenems are susceptible. It also means that anti-staphylococcal cephalosporins like first generation cefazolin, second generation cefiroxime, third generation में ceftriaxone, cefotaxime, and fourth generation में cefepime, all are susceptible. So one result of cefoxitin susceptibility predict susceptibility to all these 15 agents. The reverse is also true. If cefoxitin is resistant, it means it is resistant to all 15. It is resistant to amoxiclav, ampicillbactam, piptas, cefiprozone, sulbactam, cefotaxime, ceftriaxone, cefazolin, cefiroxime, even carbapenems also. Why? Was the question what we were discussing starting. The reason is behind the why the mechanism, what mechanism is involved in this resistance. This answer you must know, then only you'll convince your treating person. The reason is gram-negative resistance mechanism is enzyme production. It produces certain enzymes, and that enzyme is going to neutralize the drug. You introduce a BLI, you introduce an inhibitor, it will take care of, like amoxiclav. Amoxicillin is a drug, clavulate is that inhibitor for that enzyme, what organism is producing. This holds true for gram-negative. But what is the mechanism of beta-lactam resistance in gram-positive organisms? PBP mutation. The site where penicillin binds or beta-lactam drugs bind and act, that site only is changed. So if your habit of sitting in chair in this room, somebody comes and remove all the chair, well, you'll be sitting. You won't be sitting, you'll be standing. So that is the reason. The organism has a particular site where the organism is is supposed to come, sit and act. The organism stop removing it, or they prepare a chair which is not allowing sitting of that drug. So now the drug cannot act. So this drug is, this molecule or in the organism is called as PBP, penicillin binding proteins. Once that PBP is mutated, the drug whole class of drug cannot come and bind and act there. Okay, that's why once PBP mutation, that is cefoxitin resistance or MRSA happens, no BLBLI, no beta-lactam, the whole list what I talked of is going to act on the organism. Okay, this you have to convince that gram-negative resistance pattern and gram-positive resistance pattern are different. The mechanism is this and this.
इसमें एक issue है, most of the clinician are confusing the penicillinase enzyme, जो initially staphylococcus का penicillin के against में resistance का कारण था, वो एक enzyme था. लेकिन nowadays 99% of the staphylococcus aureus are producing this penicillinase enzyme, so we no longer think about it. So amoxiclav can act on a MSSA, but not on a MRSA because the chair is blocked and it cannot see.
There's one more type of predictability, what we say is not neither surrogate nor the equivalent agent, but it is one-sided and sometimes helpful. Like for example, one such classic example is tetracycline. Tetracycline as such is not used in systemic infections. Okay, it is reserved for urine for most of the organism. But if you test for tetracycline and your tetracycline is susceptible, then that patient can get doxycycline, that patient can get tigecycline, that person can get minocycline. So a tetracycline susceptibility means a lower generation of that organism, that drug susceptibility predicts susceptibility to the upper generation. So if you report tetracycline and your clinician calls, no, tetracycline I don't use, I use minocycline, give susceptibility of minocycline. You can very confidently tell, sir, if tetra is susceptible, doxy susceptible, mino susceptible, tigecycline susceptible, arvacycline susceptible. So this knowledge you must have. Okay, but the reverse is not true. If tetra is resistant, that doesn't mean that minocycline is resistant. So lower generation susceptible, upper generations also are susceptible. Lower resistant means you have to individually test each. Then only you can comment. This is another type of susceptibility. This is not equivalent or surrogate agent. Now, as far as mode of testing is concerned, usually as per CLSI, the reference method of testing is MIC based method, broth microdilution for most of the cases. Some cases may agar dilution. Disc diffusion and all, they use it, call it as a standard method. And there are two types of tests which our CLSI contains. One is a routine AST, what we do, Kirby-Burst disc diffusion or broth microdilution. And then there are some supplemental screening tests also. So there are some list of tests which are given as a supplemental test. When you go through your CLSI document, you'll find some of the supplemental tests. Like this is the list. This table 3 series in the CLSI, they have a list of tests like inducible clindamycin resistant, ESBL detection, AIIMS detection, carbapenemase detection, vancomycin screen agar, HLAR, high level aminoglycoside resistance for enterococcus. These are additional tests, not routine susceptibility. Some additional tests which you can also perform to give a better idea of particular resistance, specific type of resistance. So table 3 is something very interesting. You must open CLSI and go through these table 3 individually. Very interesting. It's very difficult to discuss all the table 3 here. Okay, then I'm moving towards what we have discussed so far is cascade reporting. There is another type of filtering what a clinical microbiologist is supposed to do in the AST is what we call as selective reporting. There is a different terminologies. Cascade reporting, you understand. Everything is susceptible. I am reporting few because I want to save serious antibiotics. Selective reporting is another type of filtering what we clinical microbiologists do in the report, but the reason is not antimicrobial stewardship. Reason is because those drugs will not act on the patient. The clinician, I don't want to make the life of the clinician difficult. I want to make it easy. So I'll only report those which I'm supposed to act. Like for example, CSF based, not every drug has an effective CNS penetration. Why to report a drug which is not going to act or has a poor CNS penetration? So like that. So any idea which among these drugs cannot be given for CSF or CNS infections? Macrolides, correct? Except meropenem, all we can't give. Drugs which are available only as an oral preparations, first generation, second generation cephalosporins, macrolide, clindamycins, tetracyclines, quinolones. Even carbapenem may be imipenem, atapenem and doripenem has poor. So if you have to select, I have to select in carbapenem, meropenem if I am treating a CNS infection. Okay. CLSI also writes, there's a nice table, 2-3 times may it have repeated. What are the drugs which you need not report in CS? Okay. Ma'am, we can let ma'am continue in between. If audience will want, we can connect again. That's not a problem. You tell ma'am. I'm okay with ma'am. Yeah. We can do that, ma'am. Yes. I'll just finish this table and then come. So this is this knowledge that which site-specific infection may what antibiotic has to be reported is very crucial as far as clinical microbiologists reporting and rounds are concerned. Okay, but it is not a hard and fast rule. The rule for certain patients may change. I'm telling you example. Fluoroquinolones, we don't use in CNS infections, but there are certain drugs which only have fluoroquinolone susceptibility. The most common is Elizabeth Kingia. Very commonly you get Elizabeth Kingia CNS infection where the only drug susceptible is either levofloxacin or minocycline. Now both the drugs have poor CNS penetration, but you have to treat the infection. So you have to give these. So there is always a plus to it that when there is a blood barrier leakage because of an infection, inflamed meninges, some sort of passage of drug can happen. If you use similar drugs in combination, they may have a certain level in the CNS. You may have to use increased doses. So we use these drugs in CSF, but in special scenarios only. Similarly, we have restrictions for urine. There are certain drugs which only can be used in urine like nitrofurantoin, norfloxacin, nalidixic acid. Then there are antibiotics which will never be working on urine, clindamycin, macrolides, chloramphenicol, tigecycline. These are drugs which never work in urine, so you don't report them in urine. So in your lab, you have to have a urine-specific panel for reporting. You have to have a blood or other site-specific panels, and you have to have a CNS panel. Minimum of 3 site-specific panel is a must for each microbiology lab to have. Urine panel, CSF panel, and all other infection panel for you to have a ease of control on this site-specific infection reporting. I think we can, ma'am, yes. Ma'am can resume back and then we'll see.
Hello.
What we have heard till now, let's have a small break of a slightly different topic and then the experts can resume. So if you have any queries, you can think of them and you can address those queries to the speakers. Fair enough? Okay. So now I would like to, Dr. Neha. Yeah. So it's entirely my pleasure to welcome Professor G. Janvi. She is head of community and family medicine here at AIIMS Deoghar and a dear friend. I would request her to take the next topic on outbreak investigations. Why did we decide on this topic? The reason was that very often we do get calls from the center and the state that we are having a suspected case of diarrhea or viral meningitis. So what exactly should be done? What are the steps of outbreak investigation? So that is what she's going to brief us about. Thank you. Thank you, Dr. Janvi.
afternoon, everyone. Thank you, Pratima ma'am, for such a sweet and nice introduction. And thank you, organizing team and microbiology team, for giving me a chance to speak about this topic today. So, I'm going to take very less time as all of you seem very tired. So, it's just a refresher type of thing, outbreak investigation. So all of you know what an outbreak is. Can we have a little interactive session so that it will be interesting? What is an outbreak? What is an epidemic? What is a pandemic? What is an endemic? All of you must be knowing. Can anyone just tell something? So just with a brief introduction type. Epidemic is what madam is telling us, right? Epidemic is?
I'm Dr. Deepa, ma'am. Epidemic is more than a defined number of cases found in a small geographical area. So that is called epidemic.
Okay. Epidemic is actually, it's correct, but it is in a wider geographic area where the more than expected frequency of disease is occurring. And endemic?
Endemic is in a normal, like some cases are always found.
Some cases are always present in that community. And pandemic?
When it involves more than 2 continents.
It involves like COVID-19 pandemic. It started in Wuhan and then everywhere it spread, the whole country. Okay, so with this a little background, I'll just go through the steps. All of you must be knowing, but I'll just go through the principles and steps of the epidemic investigation. Outbreak. What is the difference between outbreak and epidemic? Outbreak is what madam said in the beginning. In a particular area, geographic area, it is there. Epidemic is in a wider geographic area. So just to understand the principles and steps of an outbreak investigation. So what is an outbreak? We just discussed anyway. So unexpected increase in the number of cases. Suppose right now what is going on in our country? Outbreak of? So even one case of it would be an outbreak or epidemic, or many cases we need to have? Yes, even one case would be an outbreak or an epidemic. We can say an outbreak because it is not there in our country. It is like yellow fever, like these diseases which are not there in our country. Even one case would be an epidemic. So this is just your CFM classes, if you remember. The disease triad, agent, host and environment. So whenever there are any changes in this agent and host or environment, whenever there is some problem, we have cases and we have an outbreak. So it may be the problem with the agent or with the host or with the environment, with the vector having a role. So we need to identify the outbreak so that the negative impact, so that like it would reduce the negative impact and save lives of the people. So reasons why we need to investigate is identify the source, like we need to find the weakest link between the agent, host and environment. Wherever we can, we have to break the chain, then the epidemic will stop on its own. Control and prevention measures can be taken, strengthen the existing strategies, training and address public concern. So sources, how do we know that an outbreak is happening or occurring? How will we know it is there, first of all? So it may be based on the data, surveillance data, or some medical practitioner is seeing more number of cases, or from the affected groups itself, or public concern, or from the media, TV, radio, or any media. So principles are the same steps have to be followed for every type of epidemic or an outbreak. And case definition has to be clear. From the beginning, we need to have a case definition which is clear so that we can identify that number of cases, those cases only. And same questions need to be asked for all the cases. So, and like we need to keep on reassessing what is known, because it is suppose a novel like pandemic of COVID. We didn't know anything about it. So it was new for everybody in the whole world. So we need to keep on reassessing. So we were keeping on reassessing the COVID. Then only we came to know that, like suppose plasma therapy was in vogue in the beginning. Then they stopped that. And then these drugs were given, remdesivir and all. Then they stopped it. So like that, we need to keep on reassessing the situation. And then we need to keep on changing, like providing valuable information. And for that, we need data. So for that, the first thing is we need to line list the cases. Like whatever data is, whatever cases are occurring in that particular place, we need to line list the cases. That is a very important thing to do in the right from the beginning. So this is just a template, name, age, gender, all these things have to be included in the line listing. And then we need to, this is COVID-19 curve. So we need to make an epidemic curve to understand how the cases are increasing, how the cases are decreasing, what are the preventive measures. Like when there was lockdown, the cases were decreasing. And when they took out this lockdown and the gatherings started taking place, then again cases were increasing. Like that, we need to keep on, if we plot a curve, then we will come to know. So what are the steps? These are the 10 steps which we need to remember, and we need to follow the same number of steps for each and every outbreak. So first is prepare for the field work. Second step is establish the existence. Each step I'll be going through like shortly. Third is verifying the diagnosis. Define and identify cases. Describe and orient the data. Develop hypothesis. Evaluate the hypothesis, refine the hypothesis, implement control and preventive measures, and communicate the findings. So the first step is preparation for the field work. So we need to have whatever knowledge we have at that time. So with that scientific knowledge, we need to prepare ourselves, what we need to take to the field to investigate. So the microbiologist roles come here, where what samples have to be taken, what has to be taken to the field to collect the samples, how to transport the samples, what are the things, which lab is equipped with that. All these things have to be done by the microbiologist. And then the epidemiologist has to identify the team. Then at the administrative level, review the local directives or plans, and consultation has to be done with the local team. And sample questionnaire has to be prepared, and key community contacts have to be there before even going into the field, and lab containers and all these things have to be taken to the field. So this is the outbreak team: a clinician, an epidemiologist, a microbiologist, lab workers, environment health specialists, local health department, and other state agencies. So in the field work, first we need to verify whether it's a rumor or it's really true, and prepare an outbreak management kit, and brief the members of the team in the beginning itself, everybody's roles and responsibilities, so that there's no confusion when you step out into the field. And then next is establishing the existence of an outbreak. You have to make a provisional diagnosis and develop working case definition. Okay, history taking, review of records, all this has to be done. And samples, clinical samples have to be collected from the recovered cases and from the cases that are in the field. So this is the case definition, where we need to formulate a case definition. I'll give you an example. So suppose there is an outbreak of S. typhi. So you'll need a confirmed case and you'll need a probable case where there is fever, diarrhea, and whether in the confirmed case you'll find the tymphimurium also. So this is, in this, how will you, this I'll just show you the hypothesis. So this is how you have to develop an hypothesis. there is a recent increase in typhoid cases within a community. It is primarily due to contaminated drinking water from a compromised well, leading to fecal-oral transmission of Salmonella typhi bacteria among residents. This is just a hypothesis, an example of a hypothesis. So first you need to confirm the existence of the outbreak, then you need to verify the diagnosis by medical investigation, lab investigation, and epidemiological investigation. Then define and identify the cases. I showed you the example of line listing of cases. Then you need to manage the cases and search for the cases in the community, house to household search, and recording the information on the survey formats. This recording information is very important for further analysis. Then the lab investigations have to be done, proper collection, labeling, transportation, and biosafety measures have to be followed. And then you need to do a spot map, define the population, and map the area, and each dwelling unit has to be marked where the cases are found. Then you need to analyze the data and formulate a hypothesis. Then you need to evaluate the hypothesis by cohort and case control studies. If you have a defined population in that particular area, then you can do a cohort study. But if you do not have a defined population, the epidemic is from so many, like cases are reported from a large area where you do not have a defined population, there you need to do a case control study. So I won't go into details of cohort and case control. So you need to refine the hypothesis and you need to implement control and preventive measures. And then this is very important to communicate the findings to the health authorities. Daily situation updates have to be done and interim report has to be submitted by the team within a week. The report should cover the verification of the outbreak, total number of cases, time, person, place analysis, like what time it is occurring, which people are being affected, and the location where exactly it is occurring, and management of the cases, suspected sources, and control measures, and provisional hypothesis of the causation of the outbreak. Next, the final report has to be submitted within 10 days of the outbreak, which consists of the whole picture of the outbreak, precipitating factors, evolution of the epidemic, description of the persons affected, time trends, and details of the lab results. So thank you so much. So I wanted to be very short. And if any questions I can take, otherwise.
Is the Hills criteria applicable in any of any part step of this investigation for outbreak? इसको मैम जैसे hypothesis अगर बनाना है तो I think Hills criteria apply कर सकते हैं इसमें.
Hypothesis depending on that outbreak, it can be applicable, but depending on the what is the outbreak, we need to know.
Thank you.
Thank you. Thank you so much. Any other?
In each state, that is the one that the outbreak investigation team that is developed by our state government, particularly the IDSP. So they will be investing that when the outbreaks will be occurred in any part of the state. So case definition that is required. Without case definition, you can't go further. So in that team, that will be clinician, community people, microbiologists. These are the prime, and one from the IDSP people. So state, same like that, the district, same thing that will be developed everywhere. So that is the crucial part for any that the outbreaks will be occurred. Okay, thank you.
Thank you, Dr. Janvi ma'am, for enlightening us about outbreak investigation, which is the need of current days after bombardment of one by one outbreaks like COVID and currently human metapneumovirus. So I would, yes sir. to request Dr. Pratima ma'am to come and felicitate Dr. Janvi ma'am. Thank you, ma'am, again. And now I request Dr. Bhaskar sir and Dr. Ketan to resume the session.
Don't worry, we will finish within 10 minutes. And if you wish, then we can continue till 8 p.m. also. So, what you wish, 10 minutes or 8 p.m.? 10 minutes. Okay, majority says 10 minutes, so we will finish in 10 minutes. So, till he focuses his class, let us revisit the questionnaire. कम एंटीबायोटिक क्यों देते हैं? Because एक इंट्रिंसिक रेजिस्टेंस, दो इन्फर्ड रेजिस्टेंस, जैसे कि MRSA है तो बहुत सारे रेजिस्टेंस है. तीसरा कि सिमिलर स्पेक्ट्रम ऑफ इक्विवेलेंट एजेंट और some unidirectional or bidirectional susceptibility prediction. इस कारण के वजह से हम कम एंटीबायोटिक में ही पूरा स्पेक्ट्रम कवर करते हैं. दूसरा बात, हम लोग CLSI के ब्रेक पॉइंट वाला ऑर्गेनिज्म को आइडेंटिफाई करते हैं. उसके बाद ब्रेक पॉइंट, अगर हम लोग डिक्स डिफ्यूजन से कर रहे हैं तो डिक्स डिफ्यूजन से, MIC कर रहे हैं तो MIC से ब्रेक पॉइंट निकाल के बोलते हैं ससेप्टेबल और रेजिस्टेंट, जिसका बेसिक मतलब है कि ससेप्टेबल है तो नॉर्मली नॉर्मल डोज में ससेप्टेबल है, रेजिस्टेंट है तो नॉर्मल डोज में रेजिस्टेंट है. सो केतन सर, यू हैव 10 minutes to finish or 3 hours? And people have opted for 10 minutes.
10 minutes. So CLSI is such a topic we can start talking now, and maybe 5 days later we'll be sitting here only and discussing CLSI. So we'll not do that. I sincerely urge whatever we are discussing, we are just discussing how to utilize this document. Reading this document for SR and all the faculties who are there is a must, line 1 to line last. For JRs, just know the feel and concept of it. How, because you're doing the bench reporting, you should know the bench feel of the CLSI document, what breakpoints, which tables to see, all those things. Now, this is one interesting thing which I'm going to talk is direct susceptibility testing. When we do get a positive blood culture, usually you culture the organisms. From the culture organisms colony, you perform your susceptibility testing. But all these patients of bacteremia or sepsis, they are very serious. Even one day for a patient is very critical. So ultimately, we all being clinical microbiologists should start reporting the results as quick as possible, especially in these sick patients. CLSI has nicely given us one table 3F, where they talk about the direct susceptibility testing. It's a very easy method for all the common drugs. So you must go through this, okay, and read it. It's very simple. You just have to take the bottle, clean the cap of it, use a 20 gauze needle, take some broth from that, put 4 drops on a MHA, do a lawn culture, put the disc, read it over 8 to 10 hours, and that's it. Your result is available in 8 to 10 hours. This 8 to 10 hours you will utilize for direct identification from blood culture bottle. So after 8 to 10 hours of your flagged bottle, you will have the ID, you will have the susceptibility result also. What more a treating team expect in a bacteremia or sepsis patient? If you start giving your antimicrobial susceptibility testing report in 8 to 10 hours, imagine what you can do for that sick patient. So start using it, there are n number of antibiotics for which we have direct DST, direct susceptibility testing breakpoints available. UCAST has also a rapid antimicrobial susceptibility testing protocol. The only difference between CLSI-1 and this is, instead of 4 drop from a 20 gauge needle, they recommend 125 microliter. So there's a quantification of how much broth to brought out. CLSI says that reading should be at 8 to 10 hours. UCAST says that you can read at 4, 6, 8 serial hours. Otherwise, you follow UCAST, you follow CLSI, start doing direct positive blood culture bottle, DST to begin with. Okay. Now coming to the second part of our last of the discussion, this sir was talking how to know that ceftriaxone we were talking of is actually resistant or my drug, my disc are not working. So every institute, every microbiology lab should have a robust quality control. What we do is, all the batch of antimicrobial agents, we do susceptibility testing. Do we use clinical isolates while doing susceptibility testing? Answer is no. We use some reference strains. These reference strains are what we call as ATCC strains. Okay. Which ATCC strain to use in which disc is very crucial. I again want to make it very clear, this quality control testing is nowhere related to patient reporting. So you may not report a particular antibiotic in a particular organism for patient, but you still can use that organism for quality control testing. Like ceftriaxone, we don't test for, we don't report in Staphylococcus aureus, but Staphylococcus aureus ATC strain can well be used for quality control testing of ceftriaxone. There are various examples. So how we know that which ATC strain to use for which antibiotic QC? The answer is, there is a table 4 and table 5 series. The series of tables in table 4, especially 4A1 and 4A2, if you go through those pages, you will find out that these tables have quality testing for disc diffusion. If you go into table 5A1 and 5A2, these are for broth microdilution QC. Now, one thing I want to very clear, which sir very nicely pointed out, that if we test, suppose I got one disc, amikacin, and I want to know whether this amikacin disc is working or not, then what all ATCC strain I'll use. I have put a screenshot of this, the first square, for that amikacin. What are the QC strains we can use as per CLSI? We can use Escherichia E. coli ATCC 25922. We can also use Pseudomonas aeruginosa, and we can also use Staphylococcus aureus ATCC. Now, which breakpoint to use? For patient, I've shown you those table 2 list, which has clinical breakpoints. Whether we use the same for our QC testing, whether it is susceptible, intermediate, or resistant, can we do that? I have shown you clinical breakpoint tables where I have shown you S, I, R, SDD, all those. Can we use those tables for these quality control strains? Yes or no? Then what to use? These tables, the clinical breakpoint tables which we use for patient reporting of AST of a clinical isolate, the table number given is table 2. For quality control purposes, we have range. We don't have specific breakpoint. We have range. Like for example, in this table, if you can see, I think it's small, but if you try to see it, for amikacin, what is the range for E. coli ATCC 25922? How much you can read in this table? What is written? Can you read it? In that table, amikacin 30 microgram disc, Escherichia coli ATCC, if we use, what is the range given? 19 to 26. What is the mean of it? It's not clinical breakpoint. Clinical breakpoint was 26 के ऊपर आएगा तो susceptible बोलेंगे, 18 के नीचे आएगा तो resistant बोलेंगे, बीच में आ जाएगा तो intermediate बोलेंगे. This is not how a QC is read. What is the meaning of this? 90 to 26. When we do ln of E. coli ATCC, put our amikacin disc in that, then if the zone is between 19 to 26, means my disk is working. If the zone is less than 19, that means my disk is not working. Whatever result I'll be getting in the patient's clinical may be wrong. What if the disk gives more than 26? Then it means that from the company which we are buying that disk, they have forcibly added more drug in it. They are telling that the disk is 30 microgram, but they would have added 50 microgram for making sure that you always get big zones and you're happy that my discs are very fine. I get nice, beautiful zones. So when the range is given for a particular ATCC strain and an antibiotic, it should be within that range. Going above that range is also wrong, and going below the range is also wrong. So the range says 90-26. If it is less than 19, bad, your disk is not working. If it goes beyond 26, still bad, your disk is not working. So we get QC ranges. Similar ranges are for disk diffusion, similar ranges are for MIC. We always record our ATCC using these ranges to find out whether my drug powder for broth microdilution or my disk is working. And these tables only give us the list of ATCC strains which we are supposed to use. If you ask me, do we need to test all the ATCC strains what they recommend? My answer is no. Make sure that every antibiotic disk you have is at least tested by 2 ATCC. Okay, you select by yourself whether you want to keep it for E. coli, Pseudomonas or Staph aureus. For MIC, you have more number of ATCC strains, but you have to make sure that every disk is tested by at least 2 ATCC strain to give a reliable QC. Okay, and you go through these table 4 and 5. This is the appendix table which sir was talking of, which gives a nice list of intrinsic resistance in CLSI. But I have a point to mention here. There are certain drugs which are mentioned as intrinsic resistant in CLSI. Then UCAST also has a document which also enlists IR drugs. What you have to do is, you have to prepare your own table in which you incorporate both CLSI and UCAST IRs and then use it. I'll give you a very classic example. The classic example is ceftriaxone cefotaxime of Acinetobacter. CLSI has breakpoint for ceftriaxone and cefotaxime, but UCAST and other guidelines very clearly mention ceftriaxone cefotaxime to be intrinsically resistant for Acinetobacter. So there are places where CLSI and UCAST differ in that IR. What to select? For reporting, doesn't matter what you select, CLSI or UCAST. Most of us select CLSI, but as far as intrinsic resistance is concerned, we have to agree to both. So you prepare your IR chart, which incorporates list of UCAST IRs, intrinsic resistance, as well as CLSI. Stuck it on your reporting wall and always look into it while you do the reporting. Now this last thing I am going to talk of is a document which I want all the SRs and faculties to read line 1 to line last. That CLSI document is M39. Okay, M39 is a document, is not for JRs. JRs, please don't look towards this screen. Close your eyes. Okay, so M39 is a document which is very important for antibiogram preparation and is an excellent document. Again, it's a paid document. If you catch hold of piracy, don't tell me. I'm not promoting piracy, but you can use this pirated document if you want. Read this document, all faculties and SRs especially. Intricacies of an antibiogram preparation. Antibiogram preparation for a clinical microbiology is a must. You must prepare your antibiogram, be it the total antibiogram or ICU specific, ward specific antibiogram, specimen specific antibiogram like blood, urine antibiograms, respiratory secretion antibiogram is a must for our work. It's our bread and butter. You have to make it and give it to your clinical team or treating team. How you will prepare? If you read this document, there are n number of rules which are very crucial in correct antibiogram preparation. So don't just collect data from your registers and prepare an antibiogram. Go through M39, look into the intricacies and then go about. So I'm coming to the last slide. Those who are interested in antifungal susceptibility, we have some documents for that also. East-wise, the documents are more popular. Molesman documents are very limited. The document which we currently use is M27 and M44. This is the document for yeast susceptibility. How to get access to these documents? It is freely available. This is the website. You just Google CLSI free EM100. You'll get to this login page, create a login, do the login. All the documents ka breakpoints are freely accessible. So you don't need to pay for it. You can get it free. So not using it is not an excuse. It is not, I was telling paid, but it's no more paid. The literature and knowledge part is paid. The breakpoints are not paid. Breakpoints are freely accessed. You just have to Google EM100 CLSI free. Every document is accessible in EPUB format. So you have to go page by page. It's painful, but free accessible. Okay, thank you. So we all have to try to be a clinical microbiologist. We talk of being clinical microbiologist, but we ourselves don't know the actual meaning of clinical microbiologist. So first we have to uplift to the level of a microbiologist in true sense, then to clinical microbiologist. This is how we work around. Thank you.
So I think there will be many questions. नहीं तो मुझे बहुत सारे और भी पूछना है. Any question you are free to ask, sir? तो वही है ना. So we will देखिए अब let us have a political ये कि पैलेस्टाइन का सॉल्यूशन क्या है. ट्रम्प बोलेंगे सबको उठा दो, कोई बोलेंगे न्यूक्लियर बम गिरा दो. तो मतलब इट विल बी कौन से साइड पे है, उसका पेनिट्रेबिलिटी क्या है. सो बेटर ड्रग उस पेशेंट के लिए कौन से जगह पे इन्फेक्शन है. देयर आर हंड्रेड्स ऑफ इश्यूज. तो MRSA में ड्रग ट्रीटमेंट ऑफ चॉइस में ये क्वेश्चन आया था. दैट पार्ट इज अनआंसर्ड. सो आई एम हैप्पी दैट यू हैव ब्रॉट दैट हियर. So it is not only the drug and bug, it is also the person and the system and the site where the infection is. And MRSA, vancomycin, though is the drug of choice, there are various other antibiotics which do not have a beta-lactam ring, might be susceptible, might be resistant. So if we have a smaller weapon and that drug say erythromycin हो गए, clindamycin हो गए, मतलब forget linezolid भी है. These are various other antibiotic which can also be susceptible or resistant. So in that context, मतलब that answer is a highly clinical question that will depend on the site of infection. जैसे कि हमारे से अगर if we are talking about breast abscess, तो जितना भी मेडिसिन डू until and unless we drain करे abscess को, there is no use. And if in that your lower end antibiotic, after you have drained out the abscess and lower end antibiotic is effective, not the beta-lactam one, then we can go for. So there is which is a better antibiotic is dependent on the site of infection and the patient's status and various other things.
When some points, just add some points. When someone says that vancomycin is the drug of choice for MRSA, for me this statement is exactly what I expect my MBBS student to answer. Because this is the straight line answer what I expect from an MBBS student, not from us MD microbiologist as well as from the clinical team. Why I'll tell you this, sir very rightly pointed out. Currently, if you ask me best drug for MRSA, my answer will be doxycycline. You know what is the susceptibility as percent for doxycycline in MRSA? Anybody? 90 plus. Name any center if you get less than 90% or doxycycline for MRSA susceptibility, not possible. So excellent drug. Doxy where it doesn't work. Urine mate doesn't work. What about any site where tissue penetration is there? It works wonders. What about cotrimoxazole? What is the S percent for MRSA in cotrimoxazole? Most places may 80%. So that is why we are talking.
I shared one report with sir. Yes, sir. Okay, sir.
Yeah, I think with that we'll call an end to this session. We are very grateful to Dr. Bhaskar and Dr. Ketan for this great insight, which actually excites people into asking and questions and having queries. Probably the time is too short to discuss too much, but you can always follow up during the banquet when you have your gala dinner, and you have the entire day tomorrow. So, Dr. Neha, over to you.
So I request Professor Pratima Gupta ma'am to felicitate the speakers. Professor Bhaskar Thakuria sir, please come onto the stage. And Dr. Ketan, you too. Dr. Ketan. Thank you, sir. Thank you, ma'am. So now we'll move on to a brief presentation by Biomerio, and I invite Dr. Vikas to take over. Dr. Vikas.
Good evening all. Good evening all. So I'm Dr. Vikash. I will be talking about sepsis diagnostics power of 2. We all know about sepsis. We all know about AMR, AMSP, diagnostic stewardship. I'm not going to go into a lot of details about all these things. Okay, we understand the meaning and definition of the sepsis, what is all about sepsis, and how we are going to diagnose. Now we have the conventional thing going on, and then you have automation system. So what you want, it's up to you to decide what way you want to report and how quickly you want to report. Okay, so we go on to this some current existing report that I just want to show you. The state of microbiology reporting that we have in our country. It's all NABL accredited lab. You can see it's one of the reports. You can see what kind of a reporting they are doing. So you can see from here very clearly that kind of amount of antibiotic that have been used and how they are reporting. Then again, NABL accredited lab signed by some of the fellow microbiologists. Okay. Again, you can see Pseudomonas aeruginosa reported in a urine sample, what all antibiotic they have used, and in all E. coli in a urine sample. So I just give you one question to you. We will discuss it in later on. 49-year-old male crush injury compartment syndrome treated elsewhere. Repeated debridement were done, received piptas for 4 weeks. What is the drug of choice? Imipenem, meropenem, ertapenem, any of the above. This is the report in front of you. Can you just give me an antibiotic resistance mechanism? This is an actual report that what is reported. Imipenem, meropenem is susceptible. Amikacin is susceptible. Can anyone tell me what is the resistance mechanism, and based on this report, which drug you are going to choose upon? We will discuss it later on. You just keep it in mind. Imipenem, meropenem is sensitive, and your amikacin is sensitive. Rest all are resistant. How you are going to at least tell me what is the resistance mechanism, and among these drugs, which is going to be the drug of choice finally. Okay. So AMR definition, I'm not going to go into detail. we know about the problem. These are all the problems associated with the AMR. AMR and sepsis go in hand to hand. The current scenario of sepsis and the current problem of AMR, by today we are just having this situation, and by AMR in 2050, it's going to take over to the cancer to be the most common cause of mortality all across the world. And this is the problem of the AMR associated with the sepsis. 50 million cases per year, 11 million deaths per year, and 40% of the kids who are less than 5 years of old die every year of sepsis. Stewardship, we all know the definition, diagnostic and antimicrobial stewardship, but this is a very basic definition. This is an elaborated definition of any stewardship program, any antifungal, antibacterial, whatever stewardship you want to do. This is a right dose, right frequency, right route, right duration, right combination, right quality, right cost. This cost pass is very important because the country in which we are living, cost comes very handy. You have to justify everything, whatever you are doing today. Okay? Because of which the WHO in 2022 and 2023 came with some beautiful documents, bacterial priority pathogen list and the fungal priority pathogen list. This is a critical ones. Carbapenem resistant enterobacterial, third generation cephalosporin resistant enterobacterial, carbapenem resistant Cyanobacter baumannii, and rifampicin resistant tuberculosis. They are the critical group of organism. Finally, you have the fungal group. In the critical ones, Cryptococcus neoformans, Candida auris, Aspergillus fumigatus, Candida albicans. So this is what a scenario of a patient who comes to a hospital from an emergency ward, from where you start, from the initial antibiotic therapy, as Dr. Ketan just mentioned, you develop a cumulative antibiogram, you have an empirical antibiotic policy in your hospital, based on which you start a certain antibiotic, following which, but before starting an antibiotic, you collect the sample. You send the sample for an ID and AST, following which you use the targeted therapy. Once you have the ID and once you have the AST, you have the MICs, you have the disc diffusion diameters. Okay, I will be only talking about the MIC because I am from bioMero. I will only talk about the MIC part. I'm not going to go into deal with the disc diffusion. Okay, so AST. So based on which you would have the MICs and based on which you develop a personalized therapy. At what antibiotic, at what frequency, at what dosing you will give to that certain patient in a different clinical scenario. Okay, following which you have to also stop the antibiotic or you have to de-escalate the antibiotic. At what point of time you will stop the antibiotic? Okay, so you will have some certain biomarkers. You have a CRP and a procal. You will see the procal from the baseline value. After 4 days, if the procal value comes down by 80%, think of it, my patient is responding. You should de-escalate the antibiotic. But this is only possible in only 2 subset of patient, not in all. It's only for the lower respiratory tract infection and a sepsis patient. Clear, confirmed sepsis patient. Okay, just not only SOFA scoring and you're not getting anything on a any identification. My microbiology negative. It has to be a correctly identified sepsis patient. In only these 2 subset of patient, you will use a procal. Otherwise, you will not use a procal for de-escalating antibiotic. Okay. Following which, surviving sepsis guideline. Many times it has been changed, revamped, 2016, 2018. So what they say, obtain blood cultures. What is the status of a blood culture? How many times we send the blood culture and how many times we report it correctly? At what time we report the blood cultures? Okay, you obtain the blood cultures prior to administration of antibiotic. What are our understanding? How many of us are using a paired blood culture approach or set, at least a set? Forget about the paired, at least a set. How many of you? Even if you are using a set, how many of you are using an aerobic plus anaerobic? We read all those fancy Western guidelines, but we do not follow them actually. Okay? So that is why I'm just going to talk about what is the importance of an anaerobic bottle. Someone can justify that I am using aerobic bottle, 2 aerobic bottle, that's completely justified, but in the books, when you see, whether you're using a Kohnman or any book, they clearly mention you have to use an aerobic and an anaerobic. Okay? So why is blood culture important? Everyone knows about. You have to diagnose sepsis. A patient is in sepsis, is in ICU, you have to diagnose sepsis as early as possible. So this is what is our understanding about the anaerobic bottle. Anaerobic bottles have inferior growth. Or am I dealing with an anaerobic organism? How many times we get an anaerobic organism in the blood growing in a sepsis patient? Hardly. It's very rare. It's even less than 4% of an anaerobic organism which grow when you have something. Okay? So this is a myth, but the correct fact is it may not be immediately apparent to the clinician that the majority of the clinically significant aerobic bacteria are actually facultative anaerobes. And when I say this, it's enterobacterials, This is the first Staphylococcus aureus. They grow better in the anaerobic bottle much more faster than the aerobic bottle. Not only this, recent AIIMS guideline, they only said in one of the poster presented by one of my colleague, it was mentioned Candida glabrata. Not only glabrata, aureus also grows better in an anaerobic bottle rather than in an aerobic bottle. It grows faster, okay? So what is an ideal blood culture set? This is an ideal blood culture set. This has to be there, but we are not using it. One aerobic, one anaerobic bottle. So what is the blood culture order? Forget about the third part. We haven't reached to the second part. This is the complete number of bottles that you should be using in a sepsis patient, at least. But in our country, cost has to be justified. At least you should go for the first set. Better, if you have to increase your understanding about the blood culture, at least go to the second set. This is what is called the paired blood culture approach. Okay? Any book you see, they only mention this. Okay? So this is how you have to justify. So when should the blood culture be drawn? We all know that blood culture should be drawn before any antibiotic you have given to the patient. Guidelines for blood culture set, there are many guidelines. I will just highlight important one. CLSI M47A, Cumitec 1C, and European European Manual of Clinical Microbiology. When the CLSI IDSA only said, in this one of the papers, they only said volume, order of draw, number of sets, distribution between aerobic and anaerobic bottle. These are the 4 important components for any blood culture system. This should be your quality control, your quality parameters, quality indicators for your blood culture reporting. This important picture we all know about, increasing the volume. This is what is happening. When you increase the volume of the blood collected, you are actually increasing the chances of your detection. This is what the paper tells you about. Order of draw, first the phlebotomy team has to be trained about. The first bottle always has to be a blood culture bottle in an investigation form. If the blood culture is mentioned, always collect the blood culture bottle first. Do not go with the CBC and ESR collection first, and then you will think of blood culture. Okay, optimum strategy guideline is to collect 2 to 3 sets. This is from M47A. This is same CLSI guideline. This is what is the status of our aerobic to anaerobic. The pink is in anaerobic and the green is in aerobic. This is where we lie. The bottom third. Even the Brazil, Mexico, they are performing much better than ourselves. Okay, so we are not even utilizing the correct usage of the anaerobic bottle. This is the combined guideline which says about in USA, CLSI, Cumitec, AIIMS, Australia. Everyone says one and the same thing. Number of blood sets, 2 to 3. Okay, this is very important. Routine use of, this is one of the paper which talked about routine use of anaerobic blood culture specimen. Don't go into detail everything, but just only see this part. The highlighted 1 aerobic plus 1 anaerobic bottle plus 374 pathogen. Now think of a time when you haven't used the anaerobic bottle, you would have missed almost all these organisms, almost 31.5% negativity you would have got. Rather than having a good positivity rate, you would have got all these negatives. This is one of the paper. Another paper, these are all very beautiful paper one should go about. Relevance of routine use of anaerobic blood culture bottle. In this, what you see, among 13.5% had a positive anaerobic bottle in the absence of any aerobic bottle. And 2 out of 3 of these grew with non-obligate anaerobes. For 65.4% of the monomicrobial positive blood culture. I'm not even talking about the polymicrobial. Enterobacteriaceae or enterobacterials today, anaerobic bottle detected growth earlier than the corresponding aerobic bottle. What you want in a sepsis patient? You want the detection as early as possible. This is what you want. And this is the complete detail of the paper. You see, Enterobacteriaceae, Enterobacterial, Streptococcus, Staphylococcus species, anaerobic bacteria, number of isolates from anaerobic bottle without a positive aerobic bottle, 38. Can you think of enterobacterials being missed in out of 38 of the patient? Would you like to see this? Would not like to see this. Definitely. Anaerobic bacteria, enterobacterials. Again, you see aerobic negative, anaerobic positive. 7. If those 7 patients would have been in the ICU, then you can think of it. You would have missed, or you would have got a delayed growth. This is what maximum would have happened, and your treatment would have started in a very delayed fashion. So, another one, why anaerobic bottle? Because there are certain things in your anaerobic bottle, certain resins in your anaerobic bottle, which inactivates your antibiotics. And what are those antibiotics? If I give you a name, carbapenems, imipenem, meropenem, piptaz. These are the most common antibiotics which our patients get from outside. These are tertiary care hospital. We do not get the patient on the primary basis. We get the patient from secondary basis. They come from certain places. They already have got all these antibiotics. Carbapenem, mostly carbapenem, piptaz, so definitely start हुआ ही होगा. Okay, so that is when your anaerobic bottle performs better than your aerobic bottle. Blood culture for fungal isolation. This is the paper that I was talking about. Efficient recovery of Candida auris. You can see all those Candida auris growing better in your anaerobic bottle. Not only Candida auris, auris albicans, glabrata, cruzi, parapsilosis, tropicalis. All of them growing better in an anaerobic bottle. Okay? Again, that's the same poster that was presented in the AIIMS in 2022. In blood culture, anaerobic vials exhibit a faster time to positivity for detecting Candida glabrata compared to aerobic vials. This is not what I am saying. This is not what Biomerio is saying. This is what AIIMS paper, a poster that has been presented. TTP for Candida, time to positivity for Candida glabrata. You can clearly see the anaerobic bottle detection time. It's much lesser than your aerobic bottle. So what are the essential elements of a blood culture? What quality indicators, quality parameters you will set for your lab, for any diagnostic lab? Firstly, you have to have a pre-analytical check. What number of bottles, how many bottles you are using? Okay. Now, volume of the blood. This is very critically important. Your system that you are using today, it's not capable of detecting what is the volume of the blood. Transport to how quickly your blood bottle is transported to the lab. Even if it is transported to your lab, how quickly it is loaded into your system, that is also very important, because the automated system works on certain principle. The amount of time it is left outside the system, it is not going to give a good result, or it will give delayed positivity. Okay, analytical, how quickly you perform your gram stain, how quickly you communicate. Not only performing the gram stain is important, communication to the clinician is also very important. That is where your DST, direct susceptibility testing, you do a direct susceptibility testing. That is why the reason behind communication part was very important. How quickly you communicate. Okay? So I will not go into detail of the advantage of paired blood culture. Recovery of anaerobes, anaerobic bottle anaerobe C grow karega. But there are certain scenarios where facultative anaerobes grow better. Okay? Improved detection of facultative anaerobes, streptococci, enterobacterials, faster detection in anaerobic. There are certain conditions because of which they grow better in an anaerobic bottle. 16% of streptococci and 17% of enterobacterials grow better in an anaerobic bottle. Piptaz, ertapenem, imipenem, meropenem gets neutralized better in anaerobic bottle. Candida glabrata. Now, this is one of the systems that you might be hearing about, or you might be knowing about. This is BacT-Alert Virtuo. Now, the system what you had in the BacT-Alert 3D, in that system, you always needed to what? Open the system and then take out the bottle. This system doesn't need to do so. You just keep the bottle on the machine, and it will take the bottle automatically. And it will also, once the bottle is negative, it will also discard the bottle automatically. So your incubation temperature is always constant. This is what you want, your bottle to be incubated at the right temperature for the right period of time, so that you can think about whether I need to re-incubate or extended incubation. Certain scenario you need to incubate, extended incubation is requirement. So this is a BacT-Alert Virtuo. What? Improve sensitivity, specificity, real-time notification. It also notify you when was the blood culture bottle loaded, what was the volume of the blood, whether it was lower than the required volume or more than the above volume. Smart scanning technology, it will automatically scan the bottle, okay, and the blood level detection. This is very important, blood level detection. In the adult, what you want, 20 ml per bottle. And in the pediatric, it depends upon the weight of the patient, weight of the baby. So increase automation for the improved workflow efficiency. This is what the BacT-Alert Virtuo is all about. This is one of the system, and this is the very recent paper from 2024, which talked about when you had only BacT-Alert 3D and when you had BacT-Alert Virtuo, then in this scenario, Your post-optimization group, you can see 73.63% detection. Time from blood culture bottle loaded to final report hours, 73 hours. That was the only time you needed to actually get the positive blood culture bottles. Moving forward, I know I need to be very fast, but I will try my best to cover it up. ID and ST. Now you have done the blood culture, your patient was in sepsis, now you have collected the blood culture bottle, you have started an antibiotic, now you have sent the sample also for ID and AST. This is manual AST, problems and challenges with the manual AST. If you are not doing your quality control, the document that he said, the document you mentioned, forget, you are not reporting AST actually. You are not reporting. If you are not doing a quality control, these all are quality control parameters. If you are not following this, you are not doing actually the AST also. Forget about your reading, whatever your CLSI M100, M02, M07, whatever you are doing. If you are not doing a quality control, you are not doing your reporting actually. Okay, so this is where the automation system comes into handy, because these are all the challenges which are associated with the conventional disk diffusion. CLSI also in the 2025, they have also mentioned a very important line where they have mentioned disk diffusion from a reference method to a standard method. I'm not against this disk diffusion, but at least if you're doing the quality control correctly, it's a good system, okay? And then you have the expert system. The moment I saw you, I gave you that report, how to identify the resistance. Still, can you identify the resistance? I will come to that question again and again. Imipenem, meropenem, ertapenem, which drug you will choose? Your imipenem, meropenem is only sensitive, your fluoroquinolone was only sensitive. Can you identify the resistance mechanism? It is imperative, it is very difficult to understand. But this is where the solution, this is an advanced expert system in the YTech that gives you certain resistance mechanism, okay, which help you in identifying your identification also, okay. Why accurate identification? Why I need to identify accurately, okay. Accurate because IST to be correct only, it will be correct only if you have identified the organism correctly. Your breakpoints depend upon your ID. Your intrinsic resistance depend upon your ID. This is the snapshot of a table 2C from the CLSI document. Staphylococcus aureus and lugdunensis. See the breakpoint, sensitive breakpoint. Epidermidis, pseudointermedius and Scliferi are all the same. Genus is same, but the breakpoints are different. So, speciation is very important. Sometimes speciation is very important. CLSI recently conducted a webinar on something called as SOSA. SOSA. Please go on to CLSI website and see that webinar. It's very important. How to identify all these non-aureus species and how to report those AST. Importance of accurate organism identification. Why I need to identify correctly. A 10-year-old male presented in emergency with fever for 4 days and vomiting with abdominal pain for 4 days. Colicky tha, sab kuch tha, peritonitis tha. Finally, patient ko peritoneal fluid was sent for culture. Peritoneal fluid was sent for culture. Post-operative condition was stable. Empirically, he was started on ceftriaxone, amikacin and metronidazole. आपने peritoneal fluid का ग्राम स्टेन किया, क्या मिला आपको? Numerous pus cell and Enterobacter cloacae, which was susceptible to carbapenem but resistant to piperacillin, tazobactam, ampicillin, sulbactam. Okay, fine, very good. During this time, the antibiotic timeout was given, 72 hours of antibiotic timeout was given, but the patient still had a purulent fluid. Second time, again the sample was sent to the lab. This time around, the organism was same, Enterobacter cloacae, but it became resistant to carbapenem as well as all other beta-lactam. What would have happened? Yes, sir? Very correctly said. It's a AMC. How many times your clinician understand all these things? Am I dealing with an AMC organism? टर्मिनोलॉजी चेंज हुआ है, स्पाइस था, अभी है केस हो गया, ठीक है, और टर्मिनोलॉजी चेंज हुआ है, ऑर्गेनिज्म चेंज नहीं हुआ है, ठीक है, ऑर्गेनिज्म आज भी वही है. लेकिन हाउ मेनी टाइम्स योर क्लिनिशियन अंडरस्टैंड कि एमसी है ये, एमसी है तो मुझे कौन सा ड्रग देना है? व्हाट इज द ड्रग ऑफ चॉइस फॉर एमसी? सेफेपाइन एज पर आईडीएसए. आईडीएसए भी सब कुछ सही नहीं बोलता, आईडीएसए में बहुत फ्लॉज है. if you read very clearly between the lines, IDSA has also many flaws. Okay, I will not go into detail of it, what is the flaws in the IDSA. So this time around, so this was a hyper AMC, it was an AMC producer clearly. So the second time, it was susceptible to aminoglycoside and cotrimoxazole. So that was the treatment, and it was started, and the patient responded to it. Guess what would have happened? AMC. These are all the organisms that you should be thinking whenever you have, unless you have the correct ID. Citrobacter fungi, Enterobacter cloacae complex, Morganella morganelli, Crepusella aerogens, Providencia species, Serratia marcescens, mild to moderate and moderate to hyper. This list always you need to understand. Always need to see, am I dealing with an AMC organism? Please see your third generation cephalosporin. Please see your cefepime very clearly. Please see your cefepime. If you are not putting cefepime, possibly you are going to miss. But this is also a blanket statement. AMC may be cefepime resistant also. Okay, you have to see all these things. Similarly, for Candida, in Candida also you can see the moment you have the different identification, your treatment also changes. Cruzi glabrata, you have a mica fungin. Parapsilosis tropicalis, you have a fluconazole. Okay, so your identification is very important. How you are going to identify? Consequences, if I misidentify something, what will happen if I misidentify something? Case scenario 2, this is a case of an infective endocarditis. Okay, blood culture was sent. Patient was already started on vancomycin and gentamicin, thinking of presumably it was infective endocarditis. 3 days later, the patient required a mechanical ventilation because of heart failure.
I think please short.
Okay, sir.
Okay.
I will just remain at ID only. So Enterococcus species was isolated.
I want to add the few things. Simply just for the biomedics also, for the any other. Here that they explaining that we to perform the disc diffusion technique or any other the automated technique. Just to think about the closed system and open system. Everyone knowing that the closed system machines is better for the result purposes or quality control purposes as compared to open system. So same fashion that they here the any culture system that will be either the blood culture system or another that will be closed system, so that will be always better. So if in our state knowing in medical college have the blood culture system or any other system, so go ahead for the administration to procure such type of things, that will be better. Because उसके बिना आपका बहुत सारा अच्छे चीज़ नहीं होंगे धीरे धीरे करके. So it is better. ये जितने पढ़ाए जा रहे हैं इससे बेटर है कि हम ये समझें कि why that we to procure the blood culture system from any company, that will either biomedics, that will either BD or any other. So the result will be the better. So we can deal with the MIC better. अब डिस्क खरीदेंगे हाई मीडिया का खरीदेंगे, टाइटन का खरीदेंगे, पता चलेगा किसी का कंसंट्रेशन अलग है, जैसे कि लाइक द वी टू प्रोक्योर द सिप्रोफ्लोक्सासिलिन, दैट विल फ्रॉम द रेनवैक्सीन, दैट विल फ्रॉम द फाइजर, दैट फ्रॉम द सिप्ला. So concentration that is the differ, so price is differ. Same fashion that is here also. So you always try to procure for the better health that the closed system machines. So this is the summary. Only one question from that the which bottle to be inoculated first, that will aerobic or anaerobic?
Sir, it all depends upon what kind of a collection system you are using. If you are using a syringe and a needle, always inoculate your anaerobic bottle first. Never inoculate your aerobic bottle. Aerobic bottle always has to be inoculated first when you are collecting with a scalp ven collection system. Okay, never inoculate your aerobic bottle with a 20 ml का syringe लिया, उसमें डाला, भेज दिया. Most of the time you will give a false negative report.
सबको समझ में है कि हमें आगे बढ़ना है तो हमें ऑटोमेटेड सिस्टम में जाना पड़ेगा.
Sir, that is not
नहीं
correct.
This is the good. पहले हम बात करते थे, I am just explaining कि first we were doing the viral load testing for hepatitis B. That was in open system, but result was varied. So many companies that are preparing marketing the kits. So that was the result was varied. So that was not conclusive. So ultimately NCDC form a core committee and that evaluate that which type of the closed system or open system that is the better. So ultimately they decided that to perform the test with the closed system. So that is the monitoring, quality control monitoring, that is the important things. So open, that will when the outbreaks will be occur, any other things that will occur we to do, but when we to go for the specific, you always do with the closed system, that will be better. So same fashion that is this will be also.
See, actually, every technology comes with some certain challenges. Every technology will have certain challenges. Okay. Disk diffusion at one point of time, it was accepted. It's still done. It will be continued. What you want for your patient? This is my question. What you want for your patient? Do you want to still wait for 72 hours? If I show you AMC reporting just only for AMC, forget about other resistance mechanism. There are hundreds of plates I can show you where you will miss 90% of the time your AMC only. Most of the people, most of the budding microbiologists might not be able to understand synergy mechanism. Certain synergy, where you are placing the disc, placement of the disc is very important. And we are in very hurry. My patient is in ICU. Okay, your clinician will not wait for कि अच्छा आपने डिस्क यहाँ लगा दिया था वहाँ लगा दिया था आपका interpretation. He wants the interpretation, correct interpretation at the right time. That's the baseline. And rest is up to you. Rest, quality control is very important, that document. Your antibiogram is very important. If you are not developing your antibiogram, forget the treatment, your empirical treatment is also wrong. Your data is all flawed. So this is where your automated system comes handy, which will help you. At certain scenarios, you might require also, कि हाँ मुझे यहाँ पे कुछ नहीं मिल रहा है, then you can think of कि हाँ मैं disk लगा के देख सकता हूँ. Then you can do that. You can do your research work later on also. But at certain point of time, you have to weigh in कि where I am, am I doing the right judgment for my patient? You are dealing with a clinical sample, you are not dealing with a research sample. Okay, that's all from my side. Thank you all.
Thank you, sir, for the informative session. I would request Professor Manoj sir to felicitate Dr. Manish. सही बोला. Sorry. मेरे पास है. हाँ मेरे पास है. Dr. Vikas Ranjan. Thank you, sir, for the informative session. Now I would request ma'am and sir to felicitate the SBI team. So I'll request Shri Prashant Kumar Jha, Regional Manager SBI, Deoghar, to come onto the stage. Shri Brajesh Pati Sahai, Chief Manager SBI, RBO Deoghar. Shri Prakash Shankar Jha, Chief Manager SBI, AIIMS Deoghar. Mr. Avinash from SBI AIIMS Deoghar branch. Thank you, SBI. हाँ sir, please come on to the stage, and after that we'll take a break for tea for 10 minutes, and we'll start with the cultural event post that, followed by dinner. Please, all of you join us, all the delegates. इतने सारे delegates रहते हैं कि photo नहीं हो पाता है, तो it's a good thing, something good about it.